All right, it's a couple minutes after, so let's go ahead and get started. Welcome, everyone. My name is Trevor Turner. I am the Public Policy Director for the Minnesota Council on Disability. I'm also a board member for the Minnesota Consortium for Citizens with Disabilities. I am a white male with blonde hair and blue eyes. I use he, him pronouns. And my background is of the disability pride flag, and the Minnesota Council on Disability logo. Thank you everyone for joining the Disabled, Not Disposable, a health equity conference from the disabled patient perspective. We have an energizing agenda today with great speakers and information on how you as providers can advance health equity for the disability population. I will be your MC for the day. Before we get started, I want to acknowledge that this conference is hosted by the Gillette Children, the Minnesota Consortium for Citizens with Disabilities, Special Olympics Minnesota, and individual volunteers. The planning and execution of this conference was conducted primarily by people with disabilities, including our conference planning co-leads, Kate Barton and Catherine Jacobson. I also want to extend our utmost gratitude to our conference sponsors, Blue Cross Blue Shield Minnesota, Health Partners, and the Institute on Community Integration at the U of M, and the Minnesota Council on Disability. I also want to acknowledge that I also am someone who identifies as a disability. I am deafblind, so I'm very happy to be a part of this event. As we are in a virtual environment today, I want to walk over some quick housekeeping notes. Please keep your mics off during the duration of this conference, unless you are asking a question. To ensure accurate attendance tracking, please be sure to use your full first and last name as your Zoom username. And to ask a question, you can either raise your virtual hand in Zoom and wait to be called on, or type your question into the chat below. Our last session of the day at 2 p.m. will provide additional opportunities to ask questions on all of the content. We also want to make sure that all participants know that we will be recording these sessions to share out to those who could not attend. We are grateful to our presenters for sharing their time and lived experience with us, and almost all of our speakers today identify as having a disability. I wanted to share a few things to keep in mind as you participate and interact with our presenters. Being inclusive is about more than just providing accommodations that allow people to access a space. It also means creating a welcoming environment through acceptance. Many people have indivisible disabilities. You don't know if someone is disabled simply by looking at them, so don't make assumptions. Recognize that other communication styles may feel uncomfortable to you. For example, autistic communication can be blunt and may feel rude, but assume that the best of others and ask for clarification when you're unsure. If asking a question, always speak directly to the person you're addressing, even if they have an interpreter or assistant with them. Use plain language that is straightforward and literal. If you use jargon or acronyms, please define them. And finally, be patient. Some people may require more time to process or communicate. And remember that some people use alternative and augmented communication devices and may type instead of speaking out loud. Give them time to speak and don't make assumptions about their abilities or intelligence. Some people can use American Sign Language, real-time captioning, or screen readers, and please allow extra time for a response. So thank you for your willingness to learn, and I hope that you continue to use these tips in your daily interactions. So now I would like to move us into our first session, Ableism and Disability Bias in Healthcare, and pass the virtual mic to our conference co-leads, Catherine and Rachel.
Thank you, Trevor. For the next hour or so, we will be discussing ableism and disability bias in healthcare. Following this session, you will be able to define ableism and disability bias while understanding why the medical model of disability is problematic. You'll be given tactics on how you can challenge your own disability bias in your healthcare practice starting now. On the next slide, we have our agenda in a little more detail. So my co-presenter, Rachel, and I will provide some introductions of ourselves. We will talk about defining ableism broadly, as well as a couple models of disability and history of medical discrimination. We'll provide some common examples of ableism in a healthcare setting, walk through a case study, and finally share some recommendations for you to take back to your own practice of care. On the next slide, you'll see some lovely photos of Rachel and myself, and I will pass the mic over to Rachel to introduce herself first.
Thank you, Catherine, and welcome, everyone. It's so great to be with you in this space today. My name is Rachel Garaghty. My pronouns are she, her, and I work in the Center for Health Equity at the Minnesota Department of Health. I identify as a woman with a disability. I've been disabled my whole life, and I use a wheelchair for mobility. I am a white woman with short orange hair, and the background behind me is an open air office with some trees and tables. It's so wonderful to be here again today with you, and I'll pass it back over to Catherine.
Thanks, Rachel. Hi, everybody. My name is Catherine Jacobson Enns. I use she, her pronouns and self-identify as disabled. I am Korean American with albinism, meaning I was born in Korea. And I have Korean features, but white hair and white skin, also known as lack of pigment due to my albinism. I am legally blind, dyslexic, and have anxiety and depression, and I grew up in the disability community as both of my parents are completely blind and strong disability rights advocates themselves. I previously worked for several disability rights organizations, including the National Federation of the Blind and the American Association of People with Disabilities. I also previously served on the board of the Minnesota Consortium for Citizens with Disabilities, and while I was getting my MPH, I served on the University of Minnesota Senate Committee on Disability Issues. I currently work at Health Partners as a Health Equity Strategic Initiatives Project Manager. Every day and in almost every aspect of my life, I work towards ensuring the health equity for people with disabilities, and I'm so excited to be co-leading this conference today. On the next slide, we will start the content for our presentation on defining ableism. A core aspect of ableism is not recognizing that disability is an identity and something that one can feel proud of, just like any other identity. There are many definitions of ableism out there, 3 of which are on the screen and very much range from simple to a little more complex. I will read those now. The first one says, ableism is the discrimination of and social prejudice against people with disabilities based on the belief that typical abilities are superior. Next one says, ableism is a set of beliefs or practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities, and often rests on the assumptions that disabled people need to be fixed in one form or another. The last one says, a system that places value on people's bodies and minds based on societally constructed ideas of normalcy, intelligence, excellence, productivity, and productivity. These constructed ideas are deeply rooted in anti-Blackness, eugenics, colonialism, and capitalism. This form of systemic oppression leads to people and society determining who is valuable and worthy based on people's appearance and or their ability to satisfactorily reproduce or produce, excel, and behave. You do not have to be disabled to experience ableism. That's a lot of words, so let's work to understand what that actually means. To do this, it's important to understand what discrimination and bias against people with disabilities looks like. There are, like other forms of oppression, such as racism, there are many microaggressions towards people with disabilities. This can include avoiding contact or engagement with someone in a wheelchair, with a speech impediment, or using a long white cane. However, unlike other forms of oppression, discrimination towards people with disabilities is not as obviously harmful. It often comes from non-disabled people with good intentions, but underlying ableist bias. For example, grabbing a blind person's arm to help them cross the street, assuming that they cannot do it themselves, then getting upset when that blind person responds poorly to you, even though you did not get their consent to help them in the first place. You may not know that you did anything wrong or caused any harm since you were just trying to help, but it is causing harm to that blind individual because it's showing them that you hold an assumption that this blind person cannot cross a street. So how could you think that they could possibly contribute to society in a meaningful way? I cannot talk about ableism without talking about language. Language comes up in a lot of ways here, but I'm going to highlight two of them. First, ableist language is very commonly used in our everyday interactions. This can be very harmful. So working to change your language can help you be an ally, and changing your language can also help educate others. I think we all know that using the word retarded is offensive, but did you know that using words like lame, insane, crippled, crazy, idiot, and spaz can be just as harmful? Second, I see way too often that avoidance of the word disability, especially in DEI spaces. Disability is not a bad word. Avoiding using the word disability when talking about disabilities perpetuates the notion that disability is bad, something to avoid or something to be ashamed of. Don't be afraid to say disability or disabled. Not being comfortable even saying the word spreads that bias. Using terms like differently abled or special needs can unintentionally disregard a core aspect of someone's identity, increase the stigma of the word, and therefore the ableism in society. Another big form of oppression that people with disabilities face is called inspiration porn. Sorry. This is the idea that someone with a disability is so inspiring for just living or doing everyday things. We are not inspiring for having jobs, volunteering, getting out of bed, cooking, cleaning, going to school, etc. Thinking mundane activities like this is inspiring is showing your ableism by showing your assumption that people with disabilities cannot do these things. Just because we might do them in a different way than able-bodied individuals does not make it inspiring. In fact, I would avoid using the word inspiring or inspiration at all with people with disabilities unless you would say the same thing to them if they did not have a disability. I could go deeper into all of these, but we only have so much time today. So the last note I will make here is that disability discrimination can look very different towards people with visible/apparent disabilities and people with invisible or non-apparent disabilities. Most of the examples I provided on this slide were towards people with apparent disabilities. Discrimination or bias against someone with a non-apparent disability is almost the opposite. It's noticing someone is doing something in a different way and immediately judging them for that. Some personal examples I can share of this are when I am looking at my phone or computer screen super closely and someone tells me that I look weird or stupid when really I have a vision impairment. It's when I am screen sharing and taking notes in real time, but spell something incorrectly, and a colleague immediately thinking I am unintelligent and not that I may have dyslexia. We should work to normalize things being done in a not normal way. On the next slide, I will be showing some examples and models of disability. This is going to kind of get us a little bit more into the specific healthcare space. So there are many models of disability out there, and honestly, putting people's experiences into models like this is not always the best way to represent or to measure disability. However, it's important to point out to them for you to help give some context to the rest of our presentation and the conference as a whole today. I want to note that these models and way of thinking is a very white Western way of thinking. There are additional cultural considerations when defining disability, and these will be discussed during our panel later today on intersectionality. So the first model we have on the screen is the medical model of disability. This has a red X by it. It's a little outdated and something that does not align with disability justice. It says, the medical model of disability sees a person with a disability as broken, less than, something that needs to be fixed. It focuses on changing the individual. Where the social model of disability, which has a star by it, says it recognizes that a person is disabled not because of who they are, but because This is because society and the world around them was not created with them in mind. So this really focuses on systems change and universal accessibility. I'm going to pass the mic back over to Rachel to talk through some disability history and medical discrimination now.
Thank you, Catherine. I really want you to keep those two different models of disability in mind as we think about the history of disability in the past 200 to 300 years. Disability has always existed. For as long as there have been human beings, there have been disabilities. And disability is a perfectly natural part of the human lifespan. Some people are born with disabilities, and other people acquire disabilities as they age. We know that if we live long enough, we will become disabled people more likely than not. And yet, in spite of the fact that disability is one of the most human features of being human, it's had a very complex and stigmatized history in society and in the medical community. I won't go back throughout all of history. Many cultures throughout time have thought about disability in different ways and reacted to it differently. But for our purposes, we're going to think about disability from the 1800s onward, in conjunction with the emergence of the modern medical system. In the 1800s, all throughout that century and into the 20th century, sterilization of people with disabilities and institutionalization of people with disabilities were both medically justified treatments for disability. The goal of sterilization was to prevent people with disabilities from having children that might be disabled. And the purpose of institutionalization was to segregate people with disabilities from the rest of the world and keep them out of sight, out of mind. And that was just defined as being something that was done for their own good. Prior to World War II, in the early 1900s, really reaching its peak in the 1920s, we saw the emergence of the eugenics movement. The eugenics movement, as many of you might be familiar with, was a movement that sought to improve the human race by selectively choosing who could reproduce and who could not.
Mobile. All right, go, Shinju. I'm gonna help you.
Eugenics was something that was applied not only to people with disabilities, but people who were from different races that were stigmatized, from different social classes that were deemed inferior, and really used to control those groups of people. At the same time, after World War I, there was something a little bit different happening. The influx of soldiers returning home from war with newly acquired disabilities, physical injuries to invisible ones, led to an emerging rehabilitation movement in the US. In World War II, the rise of Nazi Germany brought with it the state sanctioned experimentation and killing of disabled children and adults. I talk about this because when Hitler did this, he called it final medical assistance. And so again, we see medical justification being used to commit atrocities against people with disabilities. It's also important to note that what the Nazi regime did to people with disabilities was what they later used later on against other groups of people, including the Jewish people, the Roma, and others. And it really was a very dark period in history. After World War II, once again, we have an influx of survivors, soldiers who were disabled during the war, survivors of Nazi concentration camps, civilians who survived attacks, all people with disabilities. And in the United States, many veterans with disabilities really led a society-wide push for more rehabilitation and vocational training models for people with disabilities. These efforts were supported by America's most prominent disabled president, Franklin Delano Roosevelt, who himself was a polio survivor. Between the end of World War II and the 1970s, America experienced the civil rights movement. And while the focus of the civil rights movement was race, advocates with disabilities began finding a place for themselves within that civil rights framework. In the 1970s, which we think is not that long ago, less than 50 years, we still had medical experimentation happening on non-consenting adults with disabilities. Most notable are the hepatitis experiments that took place at Willowbrook Institution in New York, in which people with disabilities were infected with hepatitis without their consent or their knowledge, and then studied. Also in the 1970s, the very first landmark civil rights legislation, the Rehabilitation Act of 1973, became law. When we think about the past 40 years, there are a lot more positives than negatives. In the 1980s, culminating in 1990, the landmark Americans with Disabilities Act came into law. The Americans with Disabilities Act is civil rights legislation that defines and protects the rights of Americans with disabilities to live and participate in society without discrimination. In 1999, not that long ago, there was another landmark piece of legislation called the Olmstead Act. And what the Olmstead Act did is it really changed the framework of institutionalized criminalization, and really said for the first time that people with disabilities belong in the community and not segregated in other facilities. In the 2000s, we had the passage of the Affordable Care Act and the national reckoning with pre-existing conditions and ensuring that folks with pre-existing conditions were not discriminated against by health insurance companies and health care providers. But in spite of all that progress, some troubling things remain. In the 2020s, we've seen really the explosion of genetic testing and a more subtle strain of medical discrimination when we think about people having the option to discriminate before birth against a person with a disability and make that discrimination part of their very genetic code. I am going to pass back to Catherine now.
Thank you. So all of that history has led up to today, where disability justice is starting to be recognized by the medical community. Just earlier this year, the NIH declared people with disabilities as a population that experiences health disparities. On the slide, you'll see a snippet of their press release that was released Tuesday, September 26th, 2023. The NIH's declaration will result in more funding and opportunities and research on healthcare inequities faced by the disability population. This is so important because people with disabilities seek medical attention for reasons not related to their disability, and the access and quality of that care should be equal to non-disabled patients. For example, just because I'm blind does not mean I should be less likely to get preventative care services. The next slide, we have some examples of ableism and disability bias in healthcare. So during the remainder of this conference, you will be hearing stories firsthand from patients with disabilities and their bad and good experiences that they've had with the healthcare system. This slide is meant to just provide some quick examples of ableism and disability bias in healthcare, but please stick around for the rest of the conference to hear more and keep this presentation in mind during the remainder of your learnings. So some of the examples that are on this slide say, assuming patients with disabilities do not need reproductive health care, assuming patients with disabilities cannot move their own bodies, give consent, or follow aftercare instructions, failing to understand the impact of aftercare and the additional considerations of crib time. Now, that's a concept that will come up later on in some of our panel discussions. Talking to a patient's caregiver and or helper/guide instead of talking directly to the patient themselves. Over-assigning symptoms and patient complaints are due to their disability when it could be due to some other medical cause. And then not taking pain seriously for disabled patients, assuming that they cannot feel pain or that it's just caused by other comorbidities. With that, I'm going to pass it back to Rachel to dive us into a little bit of a case study exercise.
Thank you, Catherine. All right, everyone, I want you to listen and watch very carefully because we are going to take a few moments after reading through this case study to give you the opportunity to imagine what you would do in this situation. On the case studies that we present to you today are imaginary. They do not happen to specific people, but rather they represent many of the stories that we as panelists have learned from disabled patients and their families about difficulties that they've had in receiving care. This first case study takes place in a pediatric setting. A pediatric patient is accompanied by both parents to an annual visit. The pediatric patient is deaf, as is the patient's mother. The patient's father has partial hearing from a cochlear implant. The patient's family requested an American Sign Language interpreter for the appointment, but the clinic could not secure an interpreter in time. The clinic did not notify the family that there would not be an interpreter. The nurses and the physicians spoke only to the father during the appointment. The physician wrote a referral for the pediatric patient to get assessed for a cochlear implant, assuming that both parents would want their child to hear. The family left the appointment in visible distress. I'll wait here a moment longer in case you want to read through it again for yourself. All right, I'm moving to the next slide. Now we want to turn it over to you. And we want you to think about or answer this question. You can raise your hand and speak vocally, or you can put an answer in the chat. We would ask that you, again, think back to our values as a community here today about being inclusive and accepting in your language, and also being mindful of time and giving others the chance to contribute as well. The first question I want to ask you is, how did ableism affect the patient and the patient's family? And the second question is, what could the clinic and providers have done differently?
There's some good answers coming in the chat already. Rachel, let me know if you want me to read those.
Go ahead. I am not even to see the chat.
Great. So the first one says, assumption that the goal of the appointment was for the son to be hearing. They should have clarified the goal of the appointment. Next one says, the mother and child experienced a worse outcomes in terms of communication and care, which is discrimination. Another says, didn't provide an interpreter, only spoke to the father, ignoring the patient, parentheses, child, as well as the mother, assumed that the goal would be to provide hearing support for the child without ever asking for insight from the family. Clinic could have explored if an online ASL was available to share with tablet in the clinic room. The clinic should have notified the family that they did not have an interpreter and given them the opportunity to reschedule or get their own interpreter. Another reschedule / contact family regarding no ASL interpreter or use of an online ASL interpreter. The doctor should have spoken to the whole family instead of just the father. Sometimes they can read lips. An interpreter should have been available at the clinic. We have disregarded value of deaf community and culture. Thank you all. Really, really hit the point there. Rachel, do you want to respond to any of those specifically?
Yeah, thank you, Catherine. All of you really went right to the heart of the issue. If you think about a disabled patient and what we talked to you about in terms of ableism, we see a lot of the mistakes that were made. The healthcare providers did not address the whole family. They did not take the time to make appropriate accommodations that had been requested, and they assumed that the family would want something that maybe they didn't want at all. So in your own practice, I would encourage you to just remember those lessons. And the next time that you encounter a patient with a disability or their family, whether they're a child or an adult, really remember that it is the patient's visit, and the assumptions that you have about them probably aren't true. So once again, it is just so important to value and center that person and their needs, and to be aware of their rights as well. Catherine, I'm going to turn it back over to you.
Thank you. So to conclude the official content for this first session, we wanted to share some quick tactics that you can implement to increase the disability inclusion of your care practices. This is by no means an exhausted list, and way more examples are going to be shared throughout the conference today. We've got some great panels on intersectionality and communication inclusion that are going to be able to provide some of these as well. But for the purpose of today, I'm just going to read some of these out loud. So it says, tactics you can implement in your practice now. Listen to the patient's own assessment of their health. Do not make assumptions about the patient's needs or goals. That's one that we saw in that last case study. Respect the patient as a whole person who can be both healthy and disabled. Accommodate the patient's disability-related needs as requested by the patient. So what we're saying today is not that you shouldn't provide accommodations, or you shouldn't even, or you shouldn't. It's just that you shouldn't assume what kind of accommodations they need. You should be asking them and then providing those upon request. Talk directly to the patient, not their caregiver or somebody accompanying them. Recognize that bodily autonomy exists for people with disabilities and that you do not automatically have their consent. And then be open to questioning typical practices to accommodate your patient. So for the remainder of our about 10 to 15 minutes, we would love to open it up for any questions that you might have around the larger topic of ableism and disability bias in healthcare. Like previously, feel free to raise your Zoom hand or ask a question or in the chat. We'll read those aloud and answer them. And if there are no other questions, we do have a couple more case studies we can walk through together. All right, well, there will be an opportunity to still ask questions on this, or questions that might come up for the remainder of the conference. Our final session of the day is going to be kind of an open consultation conversation with all of the presenters and conference planning team. So stick around for that if you have any questions coming up. Oh, I do see one that just popped up in the chat. It says, can you speak to the history and now the current state of affairs with people unable to get the supports they need to live in community? Rachel, you are the history guru. I think I'll pass that one over to you.
Absolutely. Thank you so much, Catherine. And I really appreciate that question because I believe it is one of the most pressing issues facing the disability today, and that is the shortage of support workers and other resources to support people with disabilities from living in the community. What I want to start by saying is that people with disabilities belong in the community. That is our fundamental goal and value. The reality is that people with disabilities often need extra supports in order to live in the community. And these supports might include paid caregivers. They might include housing assistance or food assistance. They might include home modifications or work modifications. Anything you can imagine that enables a person to live their best life in the community with others. We have been living with a direct support workforce shortage for the past 5 to 6 years. The workforce shortage refers to the lack of direct support staff who are available to work for people with disabilities and support them to live independently in the community. This shortage worsened during the pandemic. That was a major disruption for the disability community, and we still haven't recovered from that workforce shortage. As a result, there are people with disabilities who, for the first time, are being forced to relocate into institutional settings for their care. There are other people with disabilities who are living in community settings like group homes, who have seen their group homes shut down. And now they have nowhere else to go. We've also seen the emergence of people with disabilities who are really in limbo, trapped in hospitals, and unable to leave and go back to the community because of lack of supports. What I can say for our providers in the audience, when you do see patients with disabilities, it's a good practice to ask them about their living conditions and are they living in a way, in a setting that they want for themselves. And as a provider, to do whatever you can to help them achieve their goals for community living. I hope that answers the question.
Yeah.
Any follow-up?
Thanks, Rachel. We've got a couple other comments in the chat I want to make sure we get to, but if anybody has follow-up on that, feel free to put it in the chat or raise your hand. The next question says, can you say more about using the term, quote, white? What does that mean and why would it only be, quote, white when disability discrimination is a global problem? I'm not exactly sure what you're referring to when saying the term white, but we absolutely agree that disability is a global problem. In fact, we have a whole panel coming up later today on intersectionality and how disability spans across races, ethnicities, and other identities. If we said anything that made it assume that this was an only white problem, I solely apologize, and that is not the intention of this. In fact, because we do have a whole panel on intersectionality, it is something that is really rooted in the disability justice movement and that everybody in the core planning team believes as well. Rachel, is there anything else you want to say to that before I read the next question?
No, thank you.
All right. The next question says, would you be willing / able to discuss how anti-fat bias is a form of ableism? While there may be disagreement about the status as a, quote, disability, it certainly means the criteria of ableism, assuming poor health due to body size, lack of access to certain spaces, etc., and seems to be substantial area of healthcare bias that is rarely discussed and addressed. Thank you so much for bringing that forward. That is absolutely true. In fact, Rachel, I think in one of your future case studies, you did address fat bias as part of or a similar experience to ableism. So do you want me to pass that one over to you again, or I'm happy to talk to it as well?
Yeah, absolutely. Why don't we take to it? So I just want to say that anti-fat bias is a form of ableism. And there's a concept that I really love, and it's called health at any size. And it makes the assumption that regardless of someone's weight or their size, they can be healthy, and that health is not equal to a certain size. I think as providers, I know that we as a society have been trained to think of fatness as a pathology. It is not. It is a natural part of being human. And to pathologize someone for being overweight is a form of ableism, is a form of bias. That does not mean that we shouldn't support people in achieving their goals for their own body. But again, we don't want to act out of our assumptions that fat is a pathology. Catherine, do you want to add anything?
I just think that you are very correct, especially from a provider perspective. I think being fat and overweight is another really hard internal bias that providers need to intentionally kind of take their space out of and relearn, as well as disability. And like you had mentioned in your comment, there are a lot of accommodations that cross between people who are fat and people with disabilities. And in fact, that population interacts a lot as well. So I think that is something that definitely does need to be talked more about in this. And if that's something that people are a lot more interested in when we think about a future conference or other sessions, I think that could be a really great idea to explore a little deeper and get more involved with people from the Minnesota fat community. Another question came in. We've got about 5 minutes left. So if you have any others, feel free to put them in the chat. And if we can't get to them during this session, we'll make sure to record them for our final session. The question says, are you hearing thoughts or ideas discussed around solutions to the workforce shortages? I see this with the sign language interpreter shortage that is projected to worsen in coming years.
Catherine, I can take that one.
Please.
So what I know is that there are efforts happening at the state and national level. I can tell you a little bit about what's happening at the state level. And the information that I'm about to tell you does not apply exactly to ASL interpreters, but I think some of the solutions might also be relevant to that workforce as well. So at this state level, first of all, we need to understand that direct support workers are funded primarily through Medicaid. And so one solution is increasing the money that we have and paying direct support workers fairly. I believe the average wage for direct support workers in Minnesota needs to be people like personal assistants, direct support assistants, and others who are usually unlicensed, is around $14 or $15 per hour, which is not a living wage. At the state level, there has been legislation to increase the wage for some direct support workers, which will be coming into effect in the new year. However, In addition to money, there is also an absence of really a pipeline to help people see themselves in those caring professions and wanting to make a career out of that. And that is a workforce issue and an education issue. And one of the ways that we could think about solving it is by helping folks see themselves in caring professions and really as a society, as communities, valuing and elevating those professions, not only with wages and benefits, but with recognition that they are vitally important to us. For ASL interpreters, I know that one really big gap that we have right now is the fact that ASL interpreters are still predominantly a privatized field, whereas a person with a disability can use funding from Medicaid to have a direct support worker. A person who is deaf cannot use that same kind of funding to hire a personal interpreter. And so again, with that workforce, I think a combination of increasing wages and building that pipeline is what we need. Catherine, did you want to add anything?
No, I think you wrapped it up very nicely. In fact, we are just about at the end of our time. Rachel, if you want to move forward to the next slide, you can see both Rachel and I's email addresses on the slide. I believe these also got sent out to you prior to the conference. And if you have any other specific questions related to this, I'm sure we'd both be open and welcome to you contacting us individually. Like I said, there is still a session at the very end of this conference where we will open up for more questions. I see another one that came in the chat, and I'm just going to make sure I write that down so we can cover it during that session. But we want to make sure that we give some time between some of these. So we are going to thank you for listening to this first presentation today and pass it back over to Trevor.
Thank you, Catherine and Rachel. What a great presentation, and thank you for answering all those wonderful questions. As a deafblind person, navigating the healthcare system can be really challenging. So I really appreciate the presentation today. As a reminder to our participants today, if you have any further questions on this particular session or for the speakers, there will be an additional opportunity during our final breakout session at 2 p.m. this afternoon. As a reminder, please be sure to use your full first and last name as your Zoom username to ensure that we have an accurate attendance record for today's event. I believe you can rename yourself if you go to your video box or with your initials in it and right-click it and select rename, and then just type in your first and last name. And then we will now be taking a short break, about 5-minute break before our next session, which is a panel on inclusive communication starting at 11 o'clock. So we will take a short break and be back at 11 o'clock. So thank you very much. Welcome back, everyone. We are happy to move on to our next session. Before we move on to our second session, I want to again thank our sponsors of this conference, the Blue Cross Blue Shield of Minnesota, Health Partners, and the Institute on Community Integration, and the Minnesota Council on Disability. Their contributions support our ability to compensate the planning team members and speakers with disabilities for bringing their lived experience and time to this conference. And now I will pass the mic to our conference planning team member, Jonathan Murray, who will lead an informative panel on inclusive communication with disabled patients. Jonathan, whenever you're ready.
Good morning. I'm Jonathan Murray. I'm prefer any pronouns. I'm autistic, white, and quietly genderqueer in my 30s. I have long black hair, currently in a ponytail. I'm wearing glasses, headphones, a purple jacket, and I have a white background behind me. I'd really like to welcome you all. It's my honor to be hosting Kate Jurek, Dr. Kate Jurek, Cole Sorensen, Cookie Brand here for a panel on inclusive communication. Apologies, I'm blanking. So we're going to be hosting a discussion and touching on examples of different communication styles and formats that are really important in order for us to be able to be actively included and participate in our care as disabled patients. So with that, I would like to introduce Cole, Cookie, Dr. Kate Jurek, and if they can join me. And introduce themselves.
My name is Cole Sorensen. I am a young white person with short dark hair and tinted glasses, and I'm rocking back and forth in my chair. I am an autistic self-advocate and someone who uses a communication device. I am also a public speaker, educator, and writer, and I do a lot of advocacy around intellectual and developmental disability and communication access. My degree is in special education, and I work in disability policy. I'm very passionate about the rights of every person to self-determination, no matter how their disability affects them.
Kate, if you'd like to go next.
Hi, everyone. Good morning. I appreciate being here today. It's awesome to be welcomed to this panel. I've been looking forward to this for some time. And just a little bit about my experience. Again, my name is Cookie Brand. I use ASL to communicate. As some of you can see, there is an interpreter on the screen also that I am using to communicate. I work as a school counselor and at a deaf school at Deaf St. Paul, Minnesota. I'm the president. And I also participate in a lot of different programs in the area supporting the deaf. I've been really looking forward to sharing my experience with everyone today. So thank you for having me. And also, before I forget, I wanted just to say what I look like today. I have my hair pulled back. It's in braids. I'm wearing hexagon hooped earrings, and I have a gold sweater on. And my background is a little bit cluttered today. I have some positive, encouraging statements that I keep posted around me, and that's what's behind me in my background. So thank you.
Kate.
Forgot to unmute, sorry.
I'm Dr. Kate Jurek. I have a PhD from the University of Minnesota, serve on local, statewide, and national committees on disability, the author of Living in the Abyss, a poetry book on living with complex PTSD, access coordinator for the History of Science Society, and have reviewed articles for an upcoming book on disability and the National Park Service. As an accommodation for people that may have difficulty understanding my computer, my comments will be posted in the chat.
Yeah.
Well, thank you all for being here. I really appreciate your time and that you took taking the time to help build this list of questions of what you felt like was the most important things we needed to talk about here today. Let's get to the first question we have here today, which is how can doctors help patients who have communications disabilities or communication-related disabilities be active participants in their care?
I have awesome physicians, and I will tell you about some of the things they do to accommodate me. One of the most important things for me is time. I don't do anything fast. If you have only 8 to 10 minutes to spend with me, we are not going to have a successful encounter. My physicians allocate extra time for my appointments. They start my appointments by asking, "What can I do for you today?" which does a couple of things. First, it is respectful and treats me as a partner in my care. Second, it allows me the time necessary to type my response. Third, by being respectful and listening to me, it's more likely that we will have a fruitful conversation, and I am more likely to follow what the physician suggests.
Thank you so much, Kate.
No, she's not finished.
Oh.
Her program stopped.
Kerr.
Physicians are trained to use their vision when making medical assessments. I'd like to suggest that it might not be totally appropriate when dealing with people with disabilities. I can't even count the number of times physicians, medical staff, and people, in general, have looked at me, and because of ableism, often unconscious ableism, have assumed I have a severe cognitive impairment. They never assume I have a PhD. These ableist assumptions have a massive negative impact on my health and well-being. Your medical determinations can have a major impact on a disabled person's life. For example, when I was about 4, a neurologist measured my head circumference and declared that I was profoundly cognitively impaired because the measurement indicated my head was small. His determination resulted in me being institutionalized for 4 years until my mom started the process to adopt me. Please be very aware of the power you wield.
Oh, hang on.
Let me tell you another cool thing my primary care doctor did. About 2 years ago, I had a very traumatic experience with a blood draw at a specialty clinic. A few months later, my primary care doctor wanted to do some blood tests, and I told him I was very scared because of what had happened before. He went down to the lab and talked to the tech so I didn't have to be scared. It might not seem like a big thing to you, but it was to me. Think about ways you can help your patients navigate a healthcare system that helps build trust. Trust. How can provider staff better connect with you as human beings?
Okay, we're done.
It's so important to presume competence, which means to treat someone with the assumption that they are capable of understanding what's going on around them and having thoughts, preferences, and opinions whether or not they can communicate those in a way others can understand. Even if a person doesn't express themselves using language and might be under guardianship, they still need to be included in conversations about their care and treatment. Say you put someone on a new medication and they end up having an adverse side effect. That would be distressing for anyone. But if the person hadn't known about the potential for that side effect, or even hadn't been told they were starting a new medication at all, it could make the experience pretty terrifying. They wouldn't know why they suddenly felt like that, if it was permanent, if it was life-threatening. They might not have a way to ask those questions either, so rely on the information that others think to share with them to have any idea what's going on. When you share information with people, sure, it's possible they won't understand all of it, but at least they will have some information rather than none. Sharing information with people is one component, but supporting people to share their own thoughts is also really essential. When it comes to people who don't currently have a way to communicate through words, watch how the person behaves and how they react to what you do. Behavior is often communication. When people don't have a more reliable way of communicating what they want, they will use behavior to tell you what they want. Someone who flinches or pulls away when you try to examine them is communicating something. Maybe they're in pain. Maybe your hands are cold. Maybe they have trauma around having that part of their body touched. When someone reacts badly, take a step back, both figuratively and literally. Give them space and give them a moment to calm down before you ask them what's wrong. Work with people to learn what their preferences are regarding treatment. Explain what the different treatments are and what the benefits and risks of each treatment are, like the pros and cons of having surgery versus not having it. Look for signs that the person prefers one treatment path over another. Do they smile? Move or gesture? Make noises? If you have things like visual aids or choice boards available, using those things can help someone signal what they want. You need to presume that your patient can give input on their treatment, even if they are under guardianship and not legally allowed to consent to treatment. Even if you can't understand their answers, you still need to ask what they think. Even if you think they can't understand you, you still need to tell them what you're doing. You need to treat your disabled patients as thinking, feeling human beings because they are.
Thank you so much, Cole. And for the weight of that cookie.
Again, this is Cookie speaking. And Cole mentioned about how the physical behavior is sometimes a response. I 100% agree with that. I feel like when you look at someone's body language, their behavior, that is also communication. I agree with that wholeheartedly. And first, I also wanted to mention that every deaf person or deaf and hard of hearing person or deaf and blind person is not the same. We don't all communicate the same way. We have different styles. We have different preferences. Deaf, hard of hearing, deaf, blind. We can't assume that our communication styles or preferences are the same either. Also, when it comes to with the behavior, I would say specifically, that's correct. If someone touches me with cold hands, I'm going to have a physical response to that. I am going to communicate some of that. And also the messages, I would just say, ask us what our needs are. Help us to become involved. At least for myself as a counselor, a lot of times what I do when I'm working with a student of various ages, I have that I work with at the high school. Some of the older students can be as old as 22 years old. But in my experience with one of my students who needed a CDI, they wanted to become they needed a deaf interpreter in addition to a regular interpreter. Because usually a hearing interpreter is provided for communication, but a CDI is an additional need that is for this particular deaf person for understanding their message more clearly. And so when my student had a doctor appointment, they were provided an interpreter, but it wasn't efficient or smooth enough for that particular situation. They needed something a little bit different. So I think something to think about is specific needs, how we can become more involved in our care. And another example might be a situation with a student who doesn't understand, maybe they're not showing you anything maybe with their face, or they are showing you with their face that they don't understand you. It's important to check in, repeat something if needed, expound upon something if that's needed, ask for, constantly be doing that comprehension check to make sure that is coming across, because sometimes when someone is overwhelmed with the information, they may not have an opportunity to say something right away. That is really impactful, I think, to consider that body language as communication and having that comprehension check in too, because that allows us to be involved in our healthcare.
Cookie, we just had a follow-up question in the chat. If you could define CDI.
Sure, no problem. Thank you for that. CDI means a certified deaf interpreter. So it's a deaf person who is in the role of translating sign language and also providing. So basically what they do is they take in the information from the language. They understand maybe the medications or something for the day. They're able to expound in more detail about what that medication looks like, what time, like they give more detail a lot of times with the way they interpret, the way they expound upon the message that is being received for the deaf person.
Thank you so much. And thank you all for just your answers to words. Like that kind of core question so many of us face for our care. The next question that you had all felt was important to talk about is how can provider staff better connect with you as human beings to kind of see past our disabilities, or Cole, would you like to start?
Communication is not just between the patient and a physician, but involves everyone who is in contact with the patient, from the receptionist to the nurse to the lab tech to the x-ray technician. It's important to have accommodations addressed from the start. For example, how many of your online appointment formats ask if accommodations are needed? Do your receptionists routinely ask if accommodations are needed? For me, because I don't see well, it's important that staff tell me what they are doing, because it is jarring to suddenly have strange hands on me without knowing why. I've had good experiences with staff that had good training, and I've had bad experiences when interacting with staff who did not have good training in working with a person with disabilities. Those experiences reflect on the physician I'm seeing.
Kate will send it to Cole.
Just talking to me like a person is the biggest thing I want. A lot of people look at me and assume that I have an intellectual disability, which does not bother me at all. While I don't have an intellectual disability, a lot of the types of accommodations that help people with intellectual disabilities are really helpful for me as well, such as simpler, less technical language. I don't feel ashamed to be mistaken for someone with an intellectual disability, because people with intellectual disabilities have just as much worth and value as anyone else. What does bother me though is when, based on that assumption, people start talking to me using baby talk. I am a 25-year-old adult and have no interest in being offered a high five and enthusiastic praise for doing such a great job with sitting still for my flu shot full of pen names like Buddy. That wouldn't be appropriate for an adult who did in fact have an intellectual disability either. When I interview support workers to come work with me, one small thing I always like to see is if they swear in front of me, because that lets me know they see me as an adult rather than as someone with the quote unquote mind of a child. I am not saying that you all should start swearing in front of your patients with disabilities, unless that's something you tend to do in front of other patients already, I guess. But relating to them like any other person their age is important. I tend to really appreciate it when providers make just normal small talk with me, especially given that it does take me longer to respond, so it can be tempting to skip over for the sake of time. I also like it when providers ask me about my preferences with communication, like asking whether I prefer they read over my shoulder as I type messages or wait to look until I press the button to have a message read out loud. If anyone is interested, personally, I don't mind people reading as I type as long as they wait to respond until I finish. Because having people try to finish my sentences or interrupt me halfway through my train of thought is extremely frustrating. But everyone has different preferences, so asking rather than assuming is important.
Thank you, Cole. Cookie?
Yes, I totally get that, Cole. I totally get that. Getting interrupted with your process of thinking, that happens to me. You know, that happens for deaf, hard of hearing people and deaf blind people too. Part of the connection when doctors ask me questions like, how are you? How have things been going? That's personal level of a connection that I just feel makes things easier, makes our process easier. Then, you know, instead of just jumping right in and focusing on all of the issues, it makes it feel more real life. It makes me feel like we can have a successful and communication. So building that relationship really helps for me. I also wanted to make a comment about this emphasizes my experience with deaf, hard of hearing and deaf blind people. I just want to emphasize that we're all different. So maybe my communication mode is not what everyone else would use in this community. So some people use ASL interpreters and some people do not. Something that hit home, a situation I want to talk about is in my current care, something came up that I wasn't expecting. There was no interpreter there in that situation. And so I went to this appointment and I had to write notes. And so I had to think and process and write everything down and keep everything in my head so that I was able to write down everything successfully. And that was a big challenge for me. And then there was also a situation where the doctor was struggling to set up a VRI. So that's virtual interpreters on a screen. There was just a tech problem or just some kind of connection issue. And so it was not having an interpreter in person. The physician didn't know how to set that up. So they asked me to go to a different center because the VRI wasn't working. And I intervened and said, we can attempt to write notes. That's what I would prefer over using VRI. And the doctor said, no, I don't feel comfortable with that. I think you should go to a different clinic. And that was upset because I needed care immediately and I didn't have the time to go to another center. I had already said I'd prefer that we just continue this appointment with notes. That's what worked for me, but it was very frustrating to be told what would be best for me. It didn't feel like I was being treated as a human at that moment. It didn't feel like there was a relationship there as I was trying to receive my medical care. It ended up that we were able to figure out the VRI, but it was still did not feel good. I believe what we need to make sure that we have that personal interaction, that personal connection that really does help with setting the tone of the appointments.
Thank you so much. So the next question you all had wanted to make sure that we covered was, what accommodations are important for you with your providers or in medical settings, and how would you like them to be provided? And we'll start again with Kate.
First, talk to me and wait for my answer. Second, realize that while you might want me out of my wheelchair to do the exam, I can't communicate effectively if I am not in my chair. Third, be able to give an alternative explanation if you are not understood, which means you need to check whether your patient understood you. This requires more than just asking, "Do you understand?" Be aware that some cultures do not have specific words for disabilities. Be aware that some people with disabilities may have other issues such as difficulty reading, so just giving a handout may not be helpful. However, you don't have to invent the wheel. Just ask the person what works best.
On to Cole.
Longer appointments, when possible, is very helpful. It takes me longer to communicate, and I can't get through as much in a given amount of time as someone else could. Support with communication during procedures that prevent me from easily being able to access my device is also important. If I'm not going to be able to use my device for a while, for example, if I'm going to get an MRI or do a procedure where my ability to move my hands is limited, I need the provider to make a plan with me beforehand to make sure I can signal a way to stop if needed and I have a way to communicate any issues. Most of the time, it's very straightforward. I often decide on a hand signal or noise with the provider that lets them know I need to stop, and then they can either bring me my device or we can make a different plan. Like for an MRI, I tend to bring a printed board with some words and phrases I can point to. It's important that the provider listens to me and my needs rather than assuming, though. I'll sometimes get asked whether I need a sign language interpreter, but a couple times the provider has just wielded one of those video interpreter devices without asking. Being ready to provide an interpreter for anyone who needs one is great, but I personally can't communicate in sign language beyond a few basic words or phrases. I absolutely don't mind being asked whether I need an interpreter, but if you just assume I do and provide one without asking, it gets confusing for everyone involved and ends up eating into the already limited appointment time. Finally, one other accommodation that's helpful for me is having the option to have someone with me as support. For routine scheduled healthcare appointments, I typically just go by myself. But pain or heightened emotions mean that communication gets significantly more difficult for me. If I need to go to the emergency room for pretty much any reason, I need someone with me the whole time to provide support, both communication related or otherwise. Depending on how I'm doing, I may not be able to communicate with language at all and may need help staying calm for procedures. It's important that I'm allowed that support and that providers still listen to me once I am able to communicate more myself.
Thank you so much, Cole. Okay.
Yes, I can't stress more about that asking piece, right? Please ask. Everyone has their own different preferences and what works for them. So please ask. It's so important. I cannot stress that enough. There was a time when I was in the hospital and I needed several medical procedures. And at one point, when I went to the dentist, it was to get my teeth checked. No, most of the time I've had a variety of well, at this specific time, they had a variety of people interpreting. I've had VRIs in some situations at my hospital visits. When I was at the dentist, I was getting checked. It was a pre-surgery. And I asked, what does everything look like to figure out on the back end what we were going to need for accommodations for me to make sure everything worked best. So they described the room to me. They talked to me about where my head will be and that there will be a certain machine brace connected to my mouth area. I was at this situation, I was in the hospital for a week and I went to this dentist appointment and and I asked if I had an interpreter and they said, oh no, we didn't have an interpreter. And I said, well, I will need an interpreter for this surgery. And they said, oh, but the surgery is going to be really short. You're not going to need an interpreter. And I said, well, I'm not going to this appointment until I have an in-person interpreter because VRI is obviously not going to be working when I'm laying down. So I got an in-person interpreter to come to that appointment. And I was so happy for that I did that because that specific room was tiny. It would have been impossible for VRI to work. There was no way to really set that up because my head was basically like in a machine. To have an interpreter screen right there would have been impossible in front of my face to also allow the doctors and physicians there too. So I was so happy to have an in-person interpreter at that appointment. And again, it's so important. Like I said, you need to ask, because every situation is different and we may need different accommodations for different things.
Thank you so much, all of you. I know that's accommodations and talking about their impact in our lives is just so meaningful and difficult because we've all faced situations when they haven't been available. So the next question we had built, because there's so many things around medical care that you as providers and that we as patients have that create barriers for accessibility, for communicating about medical care. A lot of them you as providers may be able to influence or ask, simple as how you receive a form. So what communication accessibility is critical for other things necessary for medical care? And I'll pass it to you, Kate.
If I am in a hospital bed, my ability to communicate is quite limited. This is a time when you need to rely on the support person with me. It's usually my mom. She and I have a variety of ways to communicate without my computer. If I am so sick that I can't communicate, then listen to her. She knows me best. Please don't treat me like a blob of protoplasm. I've had that happen to me before and I detest it and am very likely to not trust that you have my best interest in mind, and may also become what others might call uncooperative, but which I would call preserving my bodily and mental integrity. What do you need?
Cole,
Anything involving phone calls is going to get very tricky for me. Although I have my communication device, using it on a phone call is too frustrating for me. Most people, when they hear a synthesized voice on a phone call, immediately assume it's just spam robocall and hang up. Even if I open with an explanation that I am a real person using a communication device, people don't have the visual cue of seeing me typing to know I have something to say, so they typically end up constantly interrupting me when I don't answer immediately. It's frustrating enough that I do not even try. Instead, when I have to make phone calls, I will either have my support worker call on my behalf while I'm sitting right there, and they will read out what I type, or I'll use a relay service where I get connected through an operator and have a text interface where I can type and the operator will read out my message. Calling medical providers with help from my support worker can get complicated, because as soon as the person on the other end realizes they aren't speaking directly to me, they get worried about confidentiality and often try to get me to verbally get on the line and confirm I am giving permission to speak to my support worker. Sometimes they will accept if I answer using my communication device, but not always. I occasionally run into that issue with relay services too, plus people often hang up on me then, when the only way I can make an appointment is by calling the clinic. This can present a major barrier if I'm not able to get through to anyone who will actually accept the call. I also run into phone-related issues with telehealth, since typically I will just give people my relay number, but that doesn't work the same as a regular phone number. It can't receive text messages. If a telehealth platform only lets me join the call by texting me a link to the number on file, I will not receive that message. And typically with telehealth appointments, a nurse will call my phone number to run through all the standard questions. But if they don't understand how a relay number works, they get confused when they call the number and don't get through right away and then hang up, but have no other way to reach me. There have been a few times where this has prevented me from being able to attend telehealth appointments at all.
Thank you so much, Cole. I'll pass it to Cookie.
Yeah, I would say I understand that completely. I feel you on that relay part. I've used that many times. I've tried to use relay to set up appointments. It's just really a difficult process. Sometimes it's faster to type, but I've also had some difficulty with it in the past. I know not all systems are the same, but we have our preferences. Oftentimes, I like to use text relay to set up my appointments, like through the computer. But I think some people don't always answer. They think it's some kind of spam call or something like that. So I'm not a person who uses like specific words, like tell her or tell them. I prefer direct communication over, speaking through someone. I would like them to speak to me directly. And I think most of us do want that direct communication. So that can be annoying at times. Also, I would say, I think just, considering the situation of telehealth specifically, I'm sorry, I missed that. My chart I've used in the past, that system. It's an app that allows you to communicate, because sometimes, to be honest, trying to call on the phone just doesn't work. I don't like it at all. So in my chart, you're able to put in information there. I say I use ASL. I would like an ASL interpreter in person, is my preference, not VRI. And that way, when I have my telehealth appointment, the person understands what my needs are. But I have shown up for my appointments and the interpreter's not there. So, typing it in is, it takes a lot. So I appreciate it when people have patience with me, but my preference really is to specifically have that planned interpreter in person. Because right now, I mean, for some, to be able to see and hear, you know, on the screen, you're able to look at someone as I'm speaking, the interpreter is there, you see the interpreter is there. That really helps the communication process, I feel. So yeah, some things are just, you know, gives you something to think about. But again, ask us to see what works.
Thank you so much. So the next question that y'all had, I thought was really important for us to talk about was what do you need doctors to understand about the impact of crib time lost to your disability so that you get care that fits. And just for everyone in the audience, I just linked to the terms document from the Critical Disability Study Collective from University of Minnesota. Crib time is the concept arising from disabled experience that addresses the way that disabled and chronically ill people experience time and space differently. It's all the extra costs that cost more time in our lives. And I will pass it to Kate.
Crib time refers to the extra time it takes to get things done when you have a disability. For example, it takes 5 hours out of my day to get dressed, eat, and use the bathroom. That doesn't count all the other time for things like bathing, getting ready for bed, and so on. That doesn't count all the administrative time my mom does for me to make things work. It took me 3 hours to type my responses for this panel. I have access to a wheelchair accessible van, so transportation for me is relatively easy. If your patient uses Metro Mobility, be aware that the ride is considered on time if it is only a half-hour late, and if your patient is crossing city lines, like from St. Paul to Minneapolis, they need to budget an hour and a half for the ride, even though it might be only 15 minutes by car. It's really important to consider a person's crib time when asking them to do something more.
On to Cole.
Besides the fact that I definitely need more time to respond, my disability at this time doesn't present in a way that causes me to lose time like that. But a related thing that can sometimes have a similar impact as far as healthcare goes is that I cannot keep track of things without a lot of support. If I have to remember to call to make a follow-up appointment, it will not happen. If you tell me to stop at the front desk on the way out to schedule the appointment, that's better. But there's still a good chance that in the 2 minutes it takes me to leave the exam room and exit to the lobby, I will have forgotten. The most consistent way for a follow-up appointment to happen is if someone can come into the room to make the appointment or come bring me to the scheduling desk directly. The same thing applies with stuff like lab work. No matter how many reminders I set myself, I'm not able to remember to do that on the correct schedule, at which point I run into issues where I maybe run out of refills on one of my prescriptions. The provider says I need to come in for labs before they can send in more refills. And as a result, I may end up going weeks or months without the prescription before I'm able to get in for labs. Fasting labs or labs that have to be done on certain times are the hardest for me, since I typically rely on support workers to help me get lab work, and their shifts may not align with those parameters. If I have to do fasting labs on a day halfway between my weekly injections, but my support worker doesn't work on the couple mornings a week that those conditions are met, it's going to take me quite a while to both remember that it needs to happen and coordinate some other way to go and to do it. I need providers to talk to me about some of those barriers and help me figure out a way to make it work, like proactively looking at when lab work is due and making a plan for how to make sure it happens, like aligning my next follow-up appointment with that window so I can get the lab work at the same time I'm at the clinic for the appointment with a reminder from the provider.
Thank you so much, Cole. Cookie?
Yeah, definitely. I would say that time thing is serious. A good example is when sometimes you set up an appointment and you're done, you're chatting, they want to give you like that last sheet of paper with your instructions. I always like to read it while I'm in the office. So if I have any questions, I can ask right there. So it really helps to have the interpreter there and the doctor there so that I can read those last minute instructions. That works best. And then I'm able to understand that information that's coming to me, because sometimes if I have a question that I want to ask, like say, for example, like I need the doctor to have a little bit of patience for me, with me if I'm reading something that I don't understand, because I might need clarification while I'm there. Yes, I can see the paper, but I also need to be able to see the interpreter. So I need that a little bit of time between so that I can read the words on the sheet and also look at the interpreter. And that goes the same for working with others, hard of hearing, deaf, blind. They're going to have different needs when it comes to that process. And people need extra time so that they're able to watch the interpreter, for example, in my case, and then also ask for clarification questions if they need to have that more expounded upon. But we need a little bit more understanding when it comes to that time for the deaf, hard of hearing, and deaf blind. It just makes sense to have a little bit more patience in those times.
Thank you so much. The next question that y'all had wanted to discuss was, what else do you want doctors to know about working with people with disabilities related to communication needs? I'll pass it to Kate.
If you are unsure about something, just ask. Most of us are used to explaining things. Treat me with respect. Talk to me, not my support person, unless I indicate it is okay. Listen to my concerns. They may be different from yours.
And we'll pass it to Cole.
Remember that adults with disabilities, including communication-related ones, are adults. The idea that an adult with an intellectual or developmental disability has the mind of a child is really harmful. Regardless of how someone's disability affects them, they still have had all those years of experiences that shape them as people. Plenty of adults with disabilities, even significant intellectual and developmental disabilities, will be interested in things like sex, drinking, and drug use. Some may be queer or trans too. One of my worst healthcare experiences as a developmentally disabled person was trying to access gender-affirming surgery. I showed up for the consultation and the surgeon sees me and immediately starts questioning me, asking me who in my life had given me the idea that I was trans and wanted surgery, if someone was pressuring or forcing me to be at the appointment, and so on. I eventually managed to convince him that I was there of my own free will and capable of understanding and consenting to surgery, but it was still just an awful experience. People with communication-related disabilities often have a lot of negative healthcare experiences like that one. So it's extra important that you take the time to establish trust with us and let us know that you will respect our rights to get care in the way we prefer and make our own decisions about our bodies and our lives.
Thank you so much, Cole. I'll pass it to Cookie.
Yeah, I want to emphasize what Cole said. Ask. It's so important to ask because you don't know what we need. We know what we need. And respect us as humans. That really hits home for me. Respect, just ask us for if there's anything specific, like a specific accommodation that we need, and to provide it once we give them that response. There are so many different experiences that I have where a doctor or a medical provider just doesn't give me what I need, what I ask for. One specific situation happened to me where I was in the hospital. I was in the hospital a lot last year for several weeks at a time. And there was a moment when a doctor came in and asked me, "Are you taking this medication regularly?" And I said something like, "Well, I try to, but I struggle with taking medication regularly." And that's a different situation. But he asked me if I'm taking it or not. And I said, "Well, sometimes I have depression and it can get very serious. And that does impact my ability to take my medication regularly." The doctor responded, "Okay," wondering, and then we're asked if I needed some kind of psych eval and adding and to consider if maybe I had other disabilities or other information that they didn't have that I could be diagnosed with. And I thought that I didn't need that. You know, I already had these other things that I knew about myself. So I'm a social worker, like I have my counselor, I have a master's degree. I have a social working degree. I'm a counselor. I'm a therapist in school. I have diagnosed myself. I have been diagnosed, but it was such an awful feeling, such an awful experience asking because they assumed that we needed it and not being respectful to me as an autonomous human.
We have just a couple minutes left, and I'd just like to thank all of the panelists for all of their time. And I see we do have a couple of questions in the chat. We will try to follow up with each of them in the medical providers Q&A session later. And I will pass it back to Trevor Turner.
Thank you, Jonathan, and thank you all to all the panelists for your authenticity and willingness to be vulnerable and share your experiences with our conference participants. As a reminder, if you have any further questions for the panelists here, there will be an additional opportunity during our final breakout session at 2 p.m. We will now take a short 5-minute break before our next session. Another great panel. This one is on intersectionality. So we will resume at noon, so 12 p.m. So look forward to seeing everyone there. Have a great one. Welcome back, everyone. We will go ahead and begin our next session. But before we move on to our third session, I want to again thank our sponsors for this conference, Blue Cross Blue Shield Minnesota, Health Partners, the Institute on Community Integration, and the Minnesota Council on Disability. And now I will pass the mic to our core conference planning team member, Milena Bates, who will lead our next panel on intersectionality. The floor is yours.
Thank you, Trevor. Hello, everyone. I'm proud to be leading this third session today. I think the first two have been really successful and informative. I'm just about to share my screen here, but I will start by doing the personal description for visual accessibility. I have a bookshelves in the background, and I'm a woman with brown hair, clear glasses, and I'm wearing a black and white shirt. And I use she, her pronouns. We did have 4 panelists planned for today, but we're going to have 3. Unfortunately, one of them is not able to join us. My slides are very minimalist because sometimes I go overboard in making sure that everything is accessible for visual and print disabilities. So if they're boring, that's why. I put in a slide for to introduce myself because 90% of the time, if I don't, I forget to do that. And it's like, oh, people don't even know who is actually talking to them. So I'm a proud member of the disabled community, and I'm an immigrant. I've lived in the United States and all in Minnesota since 2006. And I have been a citizen since 2019. I'm originally from Eastern Europe, former Yugoslavia, specifically Montenegro. My experience with advocacy is multi-dimensional, so to say. Being a self-advocate, I'm also a parent advocate. Both of my children have disabilities and IEPs and additional healthcare needs. And so I've been in that role for about 17 years. And for the last 10 years, I've been kind of increasingly doing more community advocacy. And I do various things with both direct support in the community as well as policy related long-term efforts like boards and things like that. My background in education as far as disability includes the Land Fellowship at the University of Minnesota, Partners in Policymaking Class 40, various state roles, and I'm a co-founder of Minnesota Autistic Alliance, which is a local nonprofit that started as a Facebook group, which now has 3,000 members. Our guests, I'm really excited about the group of panel guests because most of us in our community tend to prefer being introduced rather than introducing ourselves. I will read the introductions, and then if our panelists want to add something, please feel free to do that. Angela Carter is multiply disabled, chronically ill, white, queer femme dyke. She was raised working poor in a rural farm town and is the first person in her family to go to college. Angela is currently one of 2 associate directors for racial and social justice education at the University of Minnesota. Jules Edwards is an Anishinaabe writer, gardener, accountant, and disability justice advocate. She's passionate about improving child safety and disability policy. She blogs as Autistic Typing on her website and social media. Her first book, I Will Die on This Hill, Autistic Adults, Autism Parents, and the Children Who Deserve a Better World, was co-written with Megan Ashburn, and I recommend it to everyone in this conference. Jules' professional development includes leadership in education in neurodevelopmental disabilities fellowship, Association of University Centers on Disabilities National Training Director Council Fellowship, and 22 and 23 Wilder Foundation Community Equity Program Fellowship. And we also have Mai Thor. Jessica is our panelist that I've been really excited to join us, but unfortunately, due to unforeseen circumstances, she won't be able to join us. Mai Thor is a person living with disability and as a leader who has helped design more accessible and inclusive systems for people with disabilities. She believes that to fully achieve true justice, the intersectionality of all oppressions must be addressed and ableism must be eliminated. She has a master's in nonprofit and public administration from Metropolitan State University and a Bachelor of Arts from Augsburg University. She lives in Twin Cities East Metro and has 2 boys and a cat. So intersectionality, hopefully a lot of people were familiar with this term, but I know that not everyone, it's not safe to assume that everyone is. So I will say that intersectionality as a topic was one of the things that our planning team agreed was a really important thing to address, partially because as a planning team, we are led by disabled community members, and we were guided by principles of disability justice. And that's why I have this slide that lists the principles of disability justice, which are 10. I won't read all of them, but you will notice that they're also linked in the resources in the last slide. Intersectionality happens to be the first of them. And the slide also includes the disability pride flag, which is a charcoal gray flag with a diagonal band from the top left to bottom right corner, made up of 5 parallel stripes in red, gold, pale gray, blue, and green. So to define the term intersectionality, I must say that it was created in 1989 by Kimberly Crenshaw, who is a pioneering scholar and writer on civil rights, critical race theory, Black feminist legal theory, and race, racism, and the law. The reason intersectionality matters in healthcare is that our experience as a disabled patient is greatly changed by intersections with other socially disadvantaged identities. Our panelists have varied range of experience with disability, intersections of race, LGBTQ plus identity, cultural minority, as well as intersections of multiple different disabilities. If you look at statistics with discrepancies in health outcomes, those are going to be greatly changed depending on how many of these different identities a person possesses. And there's an image also on this slide, which is of Audre Lorde. It's a black and white photo of Black feminist queer author Audre Lorde. And in the image, she is standing with her hands in her pockets looking at the camera. It's the reason I put her picture on is because it was one of her quotes that I always think of when I think about intersectionality, which is there's no such thing as a single issue fight because we do not live single issue lives. So I apologize for a slightly long introduction. I think we can start with our first question. Feel free, before you answer the first question, to add anything that you feel is important in your introduction. And whoever wants to go first is good with me. If no one wants to volunteer, I can call. Okay, you go.
I don't see anyone unmuting, so I'll go ahead. So what does intersectionality mean to me? It's really reflective of the quote from Audre Lorde, is that we don't live single issue lives. For me, it means that I can bring my whole self to a space that I occupy. I'm autistic, I'm neurodivergent in other ways. I'm Anishinaabe, I'm a woman, and all of those parts of who I am impact how I show up in the world. And so my experience as all of my identities is not going to be the same as somebody who has different identities. I have different lenses that I bring to the world.
Speaking, I can go next. Hello, everyone. I'm happy to be with you all this afternoon. I am a white woman with a femdyke presenting haircut, and I'm wearing a knitted sweater today. I think that the introduction that you gave, Mylena, and Jules, your comment really says everything I would say about intersectionality in terms of my personal identities or experiences. The other thing that I would add is that I think a lot in my work about systems. And when Kimberly Crenshaw was writing and came up with the idea of intersectionality, she was thinking about how different social systems of sort of inequality and a privilege intersect with each other to then make it so that we have these particular experiences that are unique to our identities. And I think that's important to say in terms of our conversation around healthcare today, because a patient may be coming to your clinic and experiencing any number of things as a complex person in healthcare, but they could also be experiencing issues with housing or homelessness, or they may be experiencing discrimination or issues or lack of access in work or education. They may be experiencing any number of other barriers in terms of getting support services or work with the government. So there's all these different kind of institutions in our state, in our country, in our world that kind of can combine or make it so that a person is coming, has a whole lot they have to deal with, and you might not know all those things, and that all those things aren't your job, but those are still things that they're going to bring with them to your appointment or to your clinic, and they are things that impact their health. So we have to kind of think about the whole person, and to do that, we have to think about the whole experience and all of these various intersecting systems, as well as our intersecting identities.
Yeah, I like how you said that all of those things aren't necessarily your concern, but they also can't be ignored because it's all a part of who the person is. Mai?
Yeah, thank you, Mylena, and thanks for that great introduction. My name is Mai, and I am a disabled Hmong woman with multicolored hair. I don't even know what color it is anymore. Some gray. And I am here in my bedroom talking with you today. So thank you for having me. I agree and resonate and identify with what's already been said about intersectionality. And I think I would just add that, from a perspective of a person having received, lots of different health supports and needs over my lived experience. Intersectionality has always been at that, sort of foundational focal point in my life because of my lived experience and how I identify as a disabled Hmong woman and a refugee and immigrant and a mom. But I think, that's all of us, right? I mean, nobody is just a monolith. Nobody identifies as just one thing. And so I think in that sense, we're all sort of the same. And, it just adds to our human experience, and, disability is part of the human experience. And I think that when we seek out health, services or supports or whatever it is, to benefit ourselves in a health, in a health way, that's just something that comes with the territory. It's part of the human experience to have multiple identities that intersect with one another.
Right, and we have a very, I had a chance to take a peek at the registration list, and we have in our audience providers from a lot of different fields, and we also have members of the disabled community and some people who happen to be both. So I just want to recognize that it's not only providers that we're speaking to, and I'm guessing a lot of people from our community are looking for ideas of how to communicate and what to communicate to their providers. I don't know, I might actually look at the list of providers when I'm looking for somebody to go to next time, who knows? But so some of the professionals in the in this conference may be already more familiar with something called social determinants of health, rather than the idea of intersectionality. And I feel like these terms are kind of adjacent. They're not the same thing, but they are related. And I think are kind of different ways, in some ways, crucially different ways to look at the other factors that influence someone's health and who someone is as a patient and the care that they need. So are you, can you tell us how you see these two terms relating and how they show up in someone's healthcare needs?
So I'll jump in. This is Mai again. So I mean, honestly, I'm not familiar with this framework. I have zero healthcare background. But what I can say is, I'm familiar with the idea of, data and research on social determinants in other areas, right? When it involves folks with disabilities. And that's not necessarily healthcare related, but just, in other areas. I guess what I would like to, how I want to tackle this question is to just say that, so social determinants can include a varying number of things, right? But I think what often is, when you're in a doctor's office and you're receiving care, I think one thing to remember is that social determinants are often defined by social constructs, right? And so social constructs are often, when it comes to disability, perceived as a negative when it comes to disability, right? And that's a long history of oppression and marginalization and all that sort of stuff. And it's about dominant culture and what those determinants have sort of been determined by social constructs. And so I would just encourage health providers to remember that social determinants are good in order to determine the best kind of care that you need with your health needs. But when it comes to being an individual with a disability and coming to healthcare providers for their needs, let's sort of like remember that disability does not come from a place of a deficit. It comes from a place of being a part of the human experience. I would also say that lots of folks who identify as being disabled see that as a part of their identity, just as much as other folks who are a part of other marginalized communities see themselves, whether that's involving race or gender or whatever, right? Those folks identify as those individuals. And so, it's the same for me and my disability. I identify as a disabled person, and that's part of who I am. And so I think, just remember that the pre-existing social determinants of health tie back to those oppressive and marginalizing social constructs of, people who have historically been othered throughout time. And, a lot of those things determine how and impact how the kind of healthcare that we receive and the quality of care.
So I think that there is a really strong tie between intersectionality and social determinants of health. So the 5 social determinants of health are economic stability, education access and quality, neighborhood and built environment, social and community context, and healthcare access and quality. And within the Native community, I know that we have serious disparities in all 5 of those areas. So economic stability, Indigenous people are more likely to experience poverty, particularly those who have disabilities. Education access and quality. I know that depending on your school district, of course, there are school districts in Minnesota in which fewer than 40% of disabled Native children will graduate high school. And that's atrocious. But not only that, here in Minnesota, we have the highest rate of disability amongst the Indigenous population of any other race. Yet we are severely underrepresented within advocacy, within services, et cetera. And a lot of the time, because we don't have access to education about not the academic education, but education about our own disabilities, and education about services, and education about health and healthcare. There are huge disparities based on the intersection of race and disability that need to be addressed, and that significantly impacts access to healthcare. And it can be the cultural perspective that occurs often, where Native people may not know that help exists for certain things, so they may not ask for help. Or something that happens commonly with people who have chronic illness is they get really used to experiencing something, so it's not alarming to them, so they don't ask for help. And I see that a lot within the Native community, whether it is chronic pain, or whether it is executive functioning, or any other kind of need for support. A lot of the time that goes unmet because we don't have the support that we need to access the things that we need in order to live lives that feel better for us. So the intersectionality and social determinants of health are very, very strongly correlated.
This is Angela speaking. I think that these 2 things overlap or are related to one another because, or in my mind, because in lots of ways they're speaking to the same idea. So intersectionality, as I was saying earlier, and as we've already kind of talked about, was thinking about those systems, these social structures that determine our lives, or that we have to navigate in order to kind of live our life. And so when Kimberly Crenshaw was talking about intersectional systems, she was talking about the same things that folks in public health or in medicine and healthcare are thinking about when they say social determinants are health. We're thinking about those broader systems that then determine how likely someone is to experience illness or disability, and how likely they are to be able to get the care or the resources they need to kind of respond to their experience of illness or disability. So they're talking about the same systems, and it's just that then Crenshaw's work goes into identity. And a lot of people have kind of focused in on the identity piece of intersectionality, where we don't talk about the determinants of health as necessarily being based on identity, but it's all this different ways to have the same conversation. I think the point that Jules brought up a minute ago is the one that I think a lot about with these two ideas together in healthcare, because the way someone, disability or not disability, identifying as disabled or not identifying as disabled, regardless, the way someone may know how to navigate the kind of bureaucracy of healthcare can really be determined, really makes a big difference. So that's where the other kind of intersecting systems and experiences come to mind first for me, because it's really hard. As our last panel just helped us think about, it can be really hard to navigate and get medical care and get the care you need as a minoritized person. If you have these other systems of inequality happening in your life that you're navigating, it can be even more difficult. So that's why those are the things I think can be really important for healthcare providers to think about, is how do we support folks getting the resources for the care that they need, knowing those resources are out there, and getting through these bureaucracies when they may not have those skills or have the support they need without additional support.
Yeah, I don't know if this is accurate, but my impression is that there's a slightly different tone in how these two frameworks work. It seems like social determinants of health is more of this, well, this person is just in this situation, and this situation makes them have poorer health outcomes. And I feel like the intersectionality and the disability justice framework has more of an emphasis on a person's needs as a result of these identities. And as you know, it seems like that there's a shift in where the responsibility is seen to be between these two frameworks. But I could be, I'm more familiar with one than the other, so I could be wrong. But I certainly see how both of them are helpful. But I do see a slightly different perspective in how they can be applied. So I really think it's you all contributed something slightly different and really helpful. Hopefully everyone is thinking about this. And sorry, I keep accidentally clicking to the next slide before I'm ready. I'm wondering, do you have an example of when intersectional factors were not considered, and how that affected your or another person's care? And I will say that you know, personal stories are a good way to illustrate something, but also everyone is encouraged to maintain their boundaries around what they disclose. And if anyone wants to pass on any questions, that is totally okay, just in case it's not understood.
This is Angela speaking. I can jump in on question 3. A big one, well, there are a lot of these that I can pull from my own experience and the experiences I witness and support with my loved ones that are also disabled and have different various identities and as I do. So I think that in my personal experience, a big one is I have had care providers prescribe or recommend things to me that were not like I could not afford them. I could not afford those supplements. I could not afford to miss that. I could not afford to miss work. I could not drive to this place to go to this thing. So there were all of these other life barriers, whether we want to think about those barriers as social determinants of health or coming from those determinants or coming from intersecting systems, whatever, but there were obstacles that the care that was being prescribed to me was not possible for me. So I worked with a dietitian for a while, and I kept telling them, I can't afford those groceries. Like, we shop at Aldi. What can I get at Aldi that could be good for this diet you're recommending? And it was like they never heard me. And so there's just example after example around class or around money. That's a big one for me. Another one that I can think about is my family is in rural Missouri, and my parents don't have access to it is much harder for them to get to a medical care facility or get relationships established with healthcare providers in a city than it is for me now in the Twin Cities area. And I know that's true for other folks in outstate Minnesota. So that's another one, geographic barriers and what that means for care. And that's a part of our experience. And then the last one I'll just mention is that I have a queer family structure, and I have a disabled kiddo that I'm raising who identifies as trans, and their experience and the support that we give them and help them with getting their healthcare, there's a lot of nonsense that we just have to work through around that, where people aren't thinking, or where care providers aren't taking my kiddo's full experience as a disabled 16-year-old queer trans kid into effect, and then like the advocacy around that. So there's more, of course, but I think it's not seeing the full person, and as Jules said, letting the full person show up in their full humanity, and have all those things considered when we imagine a care plan or a treatment plan, or even just a relationship with that person.
So racism while experiencing medical care is a very serious reality for so many disabled people of color. And an example that I'm going to pull from my own life is I am a parent of disabled Afro-Indigenous children. And a few years ago, my daughter fell and hurt her ankle pretty badly. Her foot and ankle were pretty swollen, and I brought her to the emergency room after a little while, after noticing that the swelling wasn't going down. I just wanted to make sure it wasn't broken. And while we were at the emergency room, there was quite a long wait, which is, we all come to expect that. And my daughter kind of shut down from the sensory environment. They didn't have like a sensory friendly waiting room or anything like that. And she shut down, and ultimately she fell asleep. And when we were called back, I tried to keep her as calm and resting as possible, because that's most comfortable for her in that moment. And we had a remark from a nurse that, and the nurse said something like, well, she must not actually be in pain because she's sleeping. And it sounds insensitive until you also know the context of Black women specifically experience dismissal of their pain. And it's been documented in medical textbooks for I don't know how long. There used to be things that were written in textbooks that say that Black people feel less pain. And it's quite a dehumanizing thing to say, but then when you also take into account my daughter's disability as an autistic person who was overwhelmed and shut down from the sensory environment, using both her race and her disability against her to dismiss her pain. And as it turned out, her ankle was actually broken. but in that moment, it was like astounding to me. And as a parent, I have to keep it together. I have to be friendly and nice, even in the face of obvious discrimination, because otherwise that could affect my child's care. I could look antagonistic. And as somebody who is, I'm a light-skinned Native person, but I still experience racism as well. I don't want to be perceived as that angry mom. So I have to hold myself to a higher standard than I can hold medical professionals a lot of the time, which is absolute. It's absurd. It is absurd. But had that nurse thought things through before she said something, maybe that would have led to, more compassionate care for my child, who was feeling pretty dismissed at that time. And quite frankly, I was really angry that somebody would say that about my child. But that's an intersectionality issue that healthcare professionals should definitely be aware of, to not dismiss pain because of an outward presentation necessarily, or a person's race. So I guess that's my primary example. Thank you.
This is Mai again. And so when it comes to, intersectional factors and, receiving healthcare, I think of how, well, so I'm a Gen Xer and I grew up in the 80s and 90s. And, I think a lot of healthcare providers kind of might be slightly familiar with the, Hmong diaspora in our story, and, how we came to the US. And so intersectional factors, I think, in healthcare, you just can't deny the fact that there comes trauma, right? Lots of trauma with whatever marginalized identities you hold for yourself. And war is a definite factor in my lived experience and my intersectional identity. And there's lots of trauma obviously involved in that. And lots of folks in the US have the same experience as me when it comes to the trauma of war, and the reason why we've come to where where we're living now in our communities in the US. And so back in the 80s, when Hmong folks were kind of coming here to the US, one thing that I think health providers just didn't understand was our background in animism and our strongly held beliefs to communicate with the spirit world, to heal our physical, to help with our physical needs and mental needs, instead of seeking out Western medicine, right, and Western medical doctors. I personally don't have a lot of experience with that because I didn't grow up, practicing animism, but it was still very much a challenge and a struggle for my family. I come from a one-parent family. It was just my mom raising me and my siblings. My mom was just not equipped at all to figure out how to navigate the healthcare system with a disabled child. And so it was very challenging. We grew up in Indiana, and every time we needed to go somewhere, we needed to have a translator. But what happened in those early days, because for the most part, healthcare providers didn't provide translation or interpreters, it was always me and my siblings translating, right? And again, I'm not I have no healthcare experience. And I'm just even thinking of the phrase social determinants and how sort of like that is, I couldn't translate that into Hmong for you. And so it was just communication was a real issue. And so that was a factor, right? In my intersectional lived experience seeking out healthcare. And so I think that we've come a long way. I know that now, like whenever I call up for a doctor's appointment for either myself or one of my children, people always ask, do you need an interpreter? And that would have been great back in the 80s if we had had that. But so those are just some of my experiences. And some of the things that didn't go real well from my experience. But I think, again, back to my point about trauma, our intersectional experiences do include trauma. They really do. And so I think the bottom line is to just remember that that is also a part of what needs to be considered when providing healthcare.
I lost the panel where I needed to unmute myself for a second. That was a bit of a crisis there for a minute. Yeah, I think most of us have plenty of readily available examples of when intersectionality was not considered. I think I'm not on this panel, but yeah, for me, the dentist is the first thing that I think of, just, coming from Eastern Europe and not growing up drinking fluoride and, just thinking about how applying American standards of dentistry works for people who have grown up elsewhere. It's a super easy and obvious example, but we're having a great discussion, but we're not really getting through questions super quickly. So I'm going to try and keep it moving. I'm wondering if someone has an example of when things went, when this went really well, when intersectionality was fully considered, and what was the result?
So this is my, I think one time in my experience was when I became pregnant with my first child, my oldest. And I wouldn't say my intersectional needs were fully considered, because for my OBGYN, that was the first time ever experiencing a disabled patient who was pregnant. And so, but she's amazing, and she worked with me very closely on all of the things that I needed to help me through that process. It was so wonderful that I did it again because with my second child. But no, I mean, she was wonderful, and she's the person who actually delivered both of my kids. And there was lots of lessons learned from that experience. When being a disabled person, folks often don't even think you have sex, right? So that you can even get pregnant. But aside from that, I think the body is depending on what your disability is, and other physical and medical factors thrown in there. I mean, you have to really have a specified and unique way of being able to give you the care that fits your individual needs, right, throughout that 9-month process. And I've heard from so many other disabled moms who have also gone through that experience about all the things that they needed, right? And, different access needs that they had and all that sort of stuff. And I was a high-risk pregnancy for both of my pregnancies, but I am just thinking about a couple of the things that stood out, when I was working with my OBGYN during my pregnancies, and the fact that she listened and really researched and thought through everything, every step of the way, to make sure that things were going the way they're supposed to. And The second time with my youngest, we did things a little bit differently, and it went even better than the first time. And so it was a real learning process for the both of us, and it was real positive too. And so that was one really great experience as far as, you know, how my intersectional needs were really considered.
This is Angela speaking. I can say quickly that I have a primary care physician that knows that I need more time to process and ask questions and take notes, and then the typical very quick appointment allows. And I was taught by a wonderful friend and colleague and other disabled advocate about asking for extended time for appointments. And now my primary care doctor just knows that all of my appointments need to be extended time because of my processing speeds, and that I also may need to follow up afterwards with questions because I might not think of them in the moment, and that I may bring someone with me to my appointment to help me with all of those things. And so that's just not a thing I even have to ask for anymore. It's just kind of established that that is the kind of appointment that I need, and I need more time, and she's able to give that to me. And so I will never leave her care as long as she will have me.
I can't think of a specific example, but I do want to say that my family, my children and I, we need to seek medical care from the IHS clinic, the Indian Health Service clinics, in order to avoid racism. And a lot of the time, there are very small adaptations that make a really big difference in making us feel welcome in that environment, whether it's privacy, whether it's the way that our providers speak to us, whether it's the concern, whether it is the respect for traditional medicines, whether it's the understanding of the need for balance between our physical, emotional, spiritual health, that makes the difference. And then when it comes to things like barriers, like transportation is often one of the biggest barriers for Indigenous people who are seeking medical care, especially if they live in a rural area or on a reservation. So generally speaking, IHS clinics do a much better job meeting those intersectional needs when it comes to disabled Native people.
I think it's really obvious to me, hopefully it's obvious to others, how what the tone is in this other scenario. The tone is just, I'm going, I think Angela said, I'm never going to another person, and my just, talking in such a positive way about having children, and having a second one. And it's just the outcomes are, it's really obvious how much better the outcomes are. And I'm not saying, that tone is a scientific indicator or something, but I think the outlook is pretty important, whether you're a scientist or not. And I think I'm going to, my last two questions are kind of similar. And so because we only have time for one of them, I'm going to go to number 6 here. Wondering if you have ideas of what is one thing that healthcare providers can do in their practice starting tomorrow that would support intersectionality considerations for patients with disabilities. I think action items are always something that is helpful to leave with. So if you can think of something that it would be one change that is easy to implement, that would make a difference in patient care, I'm sure everyone would appreciate it.
So this is my, I have just two. And so when you're dealing with intersectional identities, I mean, as a disabled Hmong woman, it's been a balancing act, right, all your life, because sometimes you identify as this thing and then this thing, and it's sort of like, how do I bring all this together? But I think the bottom line for me really is to just remember, in respectful ways, when you don't fully understand, and honestly, I don't want to offend any healthcare providers, but I hate the word patient, but I'm going to use the word patient here. Just in the most respectful way with all your patients, just remember that, there's a difference between, how you address health needs of an individual from a medical perspective versus, how an individual, has perceived and internalized those health needs for themselves, right? So while you're telling patients, who have multiple identities, that they need to do this, this, and this, remember that lots of folks with disabilities are okay with being disabled. In fact, lots of folks with disabilities find pride in that. And so keep that in mind, that you may be telling them all these things that are wrong with them, but they may not see anything wrong with them, right? And maybe that goes back to social determinants, because sometimes social determinants tell us that we should not like our bodies, that we should, not, have body positive attitudes about the way we look or the way we move. But, again, how much of those determinants are actually, coming from a point of, white supremacy and white privilege, and how much of that has really socially constructed the healthcare field and its practitioners to address those needs to those individuals in that way. And so I guess that in a broader sense is kind of the message that I want to send. And I guess the second thing is, I come from a background of compliance, ADA, all that stuff. And access is such a huge thing, especially for folks who, and maybe the audience has already heard some of this already in previous sessions, but access is huge. And so as a wheelchair user, it's a huge thing when I go into a clinic and the counters are too high, or the what do you call the thing you lay on when you're being examined? When things are not at my height. And I have seen clinics that have done really good at providing access to the varying needs of folks who come in. So I would encourage all of you tomorrow, maybe right after this conference actually, to just consider those things about, like, how accessible is your clinic, how accessible is your hospital, and can everybody, no matter what their ability to level, get the care that they need, just as everybody else. So thank you.
We need to be wrapping up to take a break, but I'm wondering if Angela or Jules have any ideas for things to leave the session with.
I do. My number one suggestion is an attitudinal shift, and it is to embrace humility, whether it's cultural humility, humility about knowledge. A lot of the time, patients come into an appointment and they see their medical provider as the authority figure because you're educated, you're trained, you have experience, you know about health conditions and treatments. And patients often, they're still learning, or they may feel like they don't know as much as providers, but they are experts on what they're experiencing. And that can feel invalidating when the power dynamic is such that a provider has more power than the patient. So having the attitudinal shift towards being humble, being open to learn about not only the patient's experience, as well as their culture and their background and their lived experience in so many different ways. Because providers are experts in their field of work, but they aren't necessarily experts on their patients' real lives from day to day. So embracing humility is going to enhance that relationship. It's going to enhance outcomes. And it's really good for everyone involved.
This is Angela speaking. I know we're tight on time. I'll just say that related to both what Maya and Jules said, checking your bias and assumption is really important. That's all I'll add.
All right. Well, thank you, everyone. And thank you, Milena, and all the panelists here today for the rich discussion on intersectionality. I think it's really insightful and a really important conversation. And as a reminder, if you have any further questions for the panelists here, there will be an additional opportunity during our final breakout session at 2 p.m. So right now we'll take a short 5-minute break. I know we're slightly behind time, so maybe we'll start a few minutes after 1 o'clock. But we'll come back, I'll say maybe 12 or 1:03 or 1:04. So enjoy the quick break, and we will see you back in a few minutes. All right, welcome back, everyone. Before we move on to our final content session, I want to again thank our sponsors for this conference, Blue Cross Blue Shield, Minnesota, Health Partners, the Institute on Community Integration, and the Minnesota Council on Disability. Now I will pass the baton over to Jeff Prendergast from the Special Olympics, Minnesota, and Kate Barton, one of our conference planning co-leads, to talk about accessibility and person-centered healthcare. The floor is yours.
Thank you, Trevor.
All right. Yeah, thank you, Trevor. And thank you, everybody, for joining today. Really excited to have you all here and excited to kind of wrap it up for everybody. And I know on a personal note, I have found all the sessions today to be extremely informative. I've learned a lot myself, so hopefully you guys have everybody has taken something from the sessions that came before. There we go. So a couple quick introductions. Kate, I'll let you go first if you want to introduce yourself.
Hi, my name is Kate Barton. I am very involved with Systemics. I am involved as a health messenger, I'm a health advocate. I am a global messenger. I also serve on the MNCCD board of directors and other various organizations. And I will pass it over to Jeff.
All right. I am Jeff Prendergast. I am one of the health program managers here at Special Olympics Minnesota. I've been with Special Olympics for just over 2 years, and I oversee our Healthy Athlete program, and I do a lot of our work in terms of our inclusive health work, which involves educating providers and healthcare students about inclusive health and what does all mean. So again, I really do appreciate the opportunity to join you all today to share a little bit about some of the work that we're doing. Some of the things that we want to highlight today, and so just give you a quick high-level overview of what Special Olympics is. We will go into specifically what are some health disparities and barriers to care. Now, a lot of the things that we will go into are directly focusing on people with intellectual disabilities, but hopefully a lot of the information that we'll talk about can be relevant to any patients that you may come across. So we'll go into some of the health disparities and barrier to care. Talk a little bit about what is person-centered care. We're going to highlight some of the ways that our here at Special Olympics and even some of our partners are looking to combat some of the barriers that we'll discuss, and also the access to care and some of the work that Kate is doing. Kate is a very passionate person about health, so she's involved in a lot, and she'll highlight some of the things that she's involved in, and then hopefully maybe some ways that you as all healthcare providers or community members can get involved and help support some of the work that was discussed today, and help be an advocate for improving the health for everybody. And then we'll share some resources and tools that are available that hopefully you will find beneficial. So really quickly, going into what is Special Olympics. So if you are not familiar with Special Olympics, we are the world's largest sports organization for people with intellectual disabilities. We have over 5 million athletes of all ages from over 170 countries competing in over 30 sports. And we have had more than 1 million volunteers. And our mission here at Special Olympics is to provide year-round sports training and athletic competition in a variety of Olympic-type sports for children and adults with intellectual disabilities, giving them continuing opportunities to develop physical fitness, demonstrate courage, experience joy, and participate in the sharing of gifts, skills, and friendships with their families and other Special Olympic athletes and the community. One thing I really want to highlight is, yes, we are a sports organization, but we are so much more. One thing that is really exciting to be a part of this organization is we try to do more than sports. So we do focus a lot of our work in terms of health. So we do offer free health screenings. We try to help our athletes find follow-up care in their communities. We are integrating into schools across the state to bring our mission and bringing our unified approach to combining individuals with intellectual disabilities and those without intellectual disabilities together to be able to participate not only in sports, but other class activities, other groups, clubs, whatever it may be. And we are doing a lot of work in terms of our athlete leadership. I'm trying to empower our athletes, give them the skills and resources to take whatever they're passionate about and make it their own, and particularly around trying to especially teach them about being their own self-advocates in terms of their own health, and making sure that they have the confidence and the resources in order to take the initiative on their health. One thing I do want to highlight is we are actually celebrating our 50th anniversary this year, which is really exciting. It's grown a lot over the past 50 years, and we're excited to kind of see where things will go in the next 50 years here in Minnesota in terms of Special Olympics.
Health disparities. The NIH just announced that people with disabilities often experience a wide and variety range of health conditions that lead to poorer health and shorter lifespan. In addition, discrimination, inequity, and exclusionary structural practices, programs, and policies create barriers to timely and comprehensive healthcare, which further results in poor health outcomes. People with disabilities also belong to one or more populations with health disparities. They're even worse. The NIMHD recognizes the importance of the need for research to better understand the complexities leading to disparities in health outcomes and multi-level interventions.
Yeah, and I know this might have been mentioned earlier in one of the previous sessions, but I think it's important to highlight that this is a really exciting announcement. And a quote from the NIH director is, this designation marks an important step in an agency-wide effort to advance health equity for people with disabilities, which also includes updating the NIH mission statement to accurately reflect our goal of turning scientific discoveries into better health for all, including people with disabilities. So really excited to kind of see in the next few years what may come from this announcement, but it's really exciting to see going forward. Shifting gears a bit, so we're going to go into a little bit some of the health disparities and barriers to care. And again, just to reiterate, this is a lot of the data that we'll show focuses on people with intellectual disabilities. So again, because that's the primarily the people that we serve here at Special Olympics. But hopefully, again, you'll find some of this information useful. So first off, if we look at some of the common health disparities that we do see with people with intellectual disabilities, people with intellectual disabilities are 5 times more likely to be diagnosed with diabetes compared to the general population, 3 times more likely to be diagnosed with arthritis, 2 times more likely to have cardiovascular disease, and on average die 16 years premature than the general population. Additional stats on that, are actually people with intellectual disabilities are 2 times more likely to die before the age of 50, 3 times more likely to be admitted to the hospital by emergency room doctors, and 2 times more likely to be obese. Again, so these are some of the common health disparities that we're seeing. One of the things I do want to kind of highlight is, as healthcare professionals, things like diabetes, arthritis, cardiovascular disease are all things that can be treated or managed if individuals are able to get access to quality health education programs, resources. And again, one thing we'll kind of go into in the next couple of slides are some of these barriers, but again, these barriers are making it a little more difficult for people with intellectual disabilities to find access to those programs. And again, having access to those programs and trained and qualified healthcare professionals really does go a long way in helping to treat some of these issues.
For every 10 athletes on a U.S. Special Olympics team, 8 are overweight or obese, 7 have significant problems with flexibility, 4 need new prescription for eyeglasses, 2 have some kind of eye disease, 3 will fail a hearing test, 3 will have low bone density, 3 will have untreated tooth decay, and 1 will need an urgent referral to a dentist.
There we go. Then also kind of look at another thing to kind of look at is the cost of all this. How much does the cost of having some of these chronic conditions or health disparities impact? So if we look at people with intellectual disabilities, they represent 4.9% of the Medicaid population, but account for more than 15.7% of all expenditures. And as you can see, or as we mentioned, a number of our athletes that we see and people with intellectual disabilities are at higher risk for chronic conditions. And healthcare costs for people that do have chronic conditions are 5 times higher than those that do not have any chronic conditions. And oftentimes our athletes do have more than one chronic condition. If you look at Minnesota specifically, disability healthcare costs in Minnesota, about $15.5 billion per year, or about 34% of the state's healthcare spending is on disability healthcare costs, which accounts to about just over $21,000 per person with a disability.
Some health disparities, such as one of the biggest ones is obesity. Understand that obesity is a sensitive topic. It's okay to address obesity with patients. Be willing to work collaboratively with patients to find programs and resources to address their goals. Some programs that Special Olympics has is SoFit. SoFit is a unified fitness program that partners an athlete up with somebody that works along side by side with them to focus on the 4 pillars, which are nutrition, wellness, mental health, and well-being. Fit 5 is a general fitness program that focuses on nutrition, exercise. It has exercise cards that are basic exercise, such as a push-up. Also focuses on hydration. 29.9% of Special Olympics athletes are obese, compared to the 13% in the general population in the United States. Adults with intellectual disabilities are 2 times more likely to be obese than adults without intellectual disabilities.
Yep, and with those programs, like Kate mentioned, really a goal of those programs is really just try to educate them about, like you mentioned, healthy eating, being active, drinking plenty of water. Again, these are programs, resources that are available to the community. They're just not limited to our athletes. So, again, we try to break it down into a way that's easy for them to implement in their everyday life. And then this one is just, if we looked at specifically Minnesota, and this is from the CDC, and you can see that 41, you can't see it, but if you look at the obese column, 41.3% of Minnesotans that have a disability are considered obese, compared to 29.6% of the Minnesota population that do not have a disability are considered obese. So again, it's quite a bit higher than individuals that do not have a disability here in Minnesota. We're going to look at, so when looking at those health disparities, one of the things that we also want to look into are what are some of these barriers that may be leading to some of these health disparities. And then there are three main ones that we're going to look into. And the first one being attitude and beliefs. It's kind of the main things we'll talk about are cultural beliefs, unconscious bias, stigmatism, and then other attitudes and discrimination. And one of the things that we have learned, people with intellectual disabilities often live in communities where cultural beliefs, stigma, and discrimination make it extremely challenging for them to access services. Many live in communities without laws and policies to protect their right to health, education, services. But again, when they have access to these services and programs, it opens up the opportunity for more opportunities for education, employment, involvement in sports and other activities. And again, from a lot of the other sessions, previous sessions, I mean, this was something that was brought up. So hopefully this is just kind of reiterating some of the previous conversation that was held later today. And what also one point, again, this is something that's not just for people providing healthcare, but it's also for the people that are making the policies and the systems. These biases and beliefs and discrimination also affect those who are creating them, whether or not they know it or not.
Barriers such as systems, lack of transportation. There are many transportation options, but they aren't all reliable, such as metro mobility. That's already been discussed. Another one is medical transportation companies. Many of them may not show up to pick us up, so then we're left scrambling to cancel an appointment at the last minute. Transportation is one of those barriers that is needed to be addressed so we can access inclusive health, better healthcare. There is also poor enforcement of laws and policies, as there are not many policies in place to enforce training for healthcare physicians on how to work with people with disabilities. Poverty, we also are one of those populations that are in the poverty level due to income limits to the Social Security and being able to afford certain things. There's also limited self-advocacy. Empower your patients to take charge of their own health.
All right, and then the third one, and this is one where I think this is one of the biggest barriers, but it's also one of the biggest barriers where we have most opportunity to make an impact right away, is this knowledge, especially in terms of insufficient provider training and education. If you look at a survey that was conducted by medical schools and dental schools, they found that 81% of medical students aren't getting any type of clinical training on working with patients with disabilities. So right there, that's a huge opportunity to make a big impact if we can develop better curriculum, improve opportunities for medical students to get involved and learn more about how to care for patients with disabilities. One of the really exciting things here, especially here locally, is I do feel like a lot of the universities have made an effort to improve the type of curriculum that they are offering to their students. We've had the opportunity with several universities here locally to be able to provide training, to be able to go in and do something very similar to this conference, where we allow some of our athletes to come in and share their story. So the students can learn firsthand about what it's like for a person with a disability to get care. What are some of the barriers that we talked about that they have to overcome? Communication, how much is that is important to them and things like that. So there's a lot of opportunity for growth, and I'm excited to kind of see in the next couple of years, especially with conferences like this, opportunities for us to really make an impact in terms of that. Another one to highlight is that self-advocacy, like Kate mentioned. A lot of it is just providers aren't trained or know how they can help empower patients to be their own self-advocate. So that's an opportunity for growth and something that we're looking to overcome. And then one of the biggest ones is that diagnostic overshadowing that I hear quite a bit from our athletes when they share their story. And again, this is where you wrongly presume that present physical or emotional symptoms are a consequence of the patient's intellectual disability. And one of our individuals, and I don't think she'll mind me sharing, but she always shares the story about how she had to go see a provider around, she was having foot and ankle issues and she has braces. And essentially the provider told her that, well, you know, a lot of people with intellectual disability has foot and ankle problems and they just wear braces, you know, that's just the way it goes pretty much. And how she always phrases, and I always like how she phrases is, no, I have an intellectual disability that involves my brain up here. That has nothing to do with my feet below, with her feet. So again, it's just not taking that time to look at maybe what other issues or things might be going wrong that might be causing the issues with her feet and ankle. So that is something to kind of keep in mind.
Now we have some real life scenarios. The first one is your 36-year-old daughter with an intellectual disability still goes and sees her pediatrician. Maybe there isn't any continuity of care when it comes to transitioning a child to an adult care. That needs to be figured out and addressed so an adult can transition to a physician that they can trust.
The next one, and I do think the second session with Jonathan, they did highlight this quite really well. A doctor speaks only to your mother, refers to you in the third person, doesn't let you explain your symptoms. Again, it's their body. They are able to explain their symptoms. It may take longer, but allowing the opportunity, just being respectful, allowing them to speak on their own behalf. And I think, like I said, I think in the second session, I think they did a great job on highlighting this this issue in terms of not speaking to them directly.
And the third and final one is that your doctor doesn't understand your disability or how to best address your health needs. So sometimes doctors don't understand how a person works with a disability, and it may take a little longer for us to process and understand what you're saying. Help us with things such as follow-up care, make those before we leave.
So after going through some of the disparities and barriers, sharing some examples, one of the ways we want to focus on how to help overcome that and kind of focus on improving the care is through person-centered healthcare. And what does that mean?
What is person-centered care? Person-centered care is an integrated health care services delivered in a setting manner that is responsive to individuals and their goals, values, and preferences, in a system that supports good provider and patient communication, and empowers individuals receiving care and providers to make effective care plans together. The CMS.
Yep, that's the definition from the CMS. It's some components of person-centered care. It's care that is guided and informed by the patient's goals, preferences, and values. Success of patient-centered care is measured by patient-reported outcomes. It includes integrated and coordinated care across health systems, providers, and care settings. It focuses on managing chronic and complex conditions. And really, it's a relationship that is built on trust and a commitment to long-term well-being. And if person-centered care is integrated some of the benefits and impact it can have on patients include improve the experience that people have of care and how they'll feel more satisfied with the type of care that they're getting. It does tend to lead to more people to leading more of a healthy lifestyle, such as exercising or eating healthier. It involves patients and individuals to be more involved in the decisions about their care and the type of services and support that they get that is appropriate to their needs. And then as for providers, it can help lead to more confidence and satisfaction in the type of care that you're providing for your patients. And then looking at person-centered care from a patient's perspective to a provider's perspective. And what does it mean? So for a patient, person-centered care allows patients to make informed decisions about their treatment and well-being. They have a team of primary care providers, specialists, and other healthcare providers who know them. They listen to them and are accountable for their care. Doctors and other healthcare professionals who provide person-centered care can help manage their healthcare by providing the tools and services that align with the patient's preferences and values so they can reach their health goals. So that's what it is kind of means for a patient, but for as a provider, person-centered care means doctors and other healthcare providers work collaboratively with patients and other healthcare providers to do what is best for the patient's health and well-being. It offers healthcare providers the necessary supports, like access to patients' health data, to understand their overall comprehensive needs, providing doctors and healthcare providers with their big picture information so that they are and you are better equipped to develop care plans that include empathy, dignity, and respect for the patient, their families, and their caregivers. Kind of a good example of this would be a patient named Tyler who meets with his doctor who's having breathing problems and is diagnosed with asthma. In addition to prescribing him with a rescue inhaler to treat the symptoms, the doctor also follows up with a telehealth visit to identify any other contributing factors, such as like smoking or any other things in his current living conditions. And together they develop a plan that works for Tyler, that fits his needs and his wants. And some of the things that are included in the plan include getting Tyler connected to a smoking cessation program when he's ready to quit, but then also looks to leverage community partners and public services who can help him understand and maybe what other things that are contributing to his asthma and where he can get help to improve his living condition. So again, this is kind of a nice example because it shows involving Tyler into his care, into the care decisions, and also connecting Tyler to tools and resources that are going to be beneficial to him, but then again, that fits his needs and preferences for his overall health goals. So again, that's a kind of a great example that shows person-centered care in action. Along with person-centered care, it's also, I think it's important to kind of highlight the difference between equality and equity, and really understanding that along with person-centered care does kind of go a long way helping reduce some of those disparities and barriers that we talked about, and including people with disabilities into the care that they need. So if we first look at equality, equality ensures that everyone gets the same thing. It looks to aims to promote fairness, which again can only be achieved if everybody has that same starting point, they have same needs. But again, as we all know, that's not the case for underserved populations like those with intellectual disabilities or other disabilities. And the visual with the bikes, I think, is a good visual representation of that. So again, if we're looking at equality, everybody gets the exact same bike, which is fair. But again, that's not going to fit everybody's needs that they need. While on the other hand, equity involves understanding and giving people what they need to live healthy lives. Health equity is when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So again, what does that all mean? It means everybody should not have the same resources, but the necessary resources to achieve optimal health outcomes. And this includes addressing any barriers and prevent inclusion of people with disabilities in health programs, policies, and services. And again, if we look at the visual with equity, again, everybody was provided a bike that, again, that fits their needs and are able to allow them to ride, or the other visual where providing them what they need to be able to see the baseball game. And I think these are some really nice representations of what equality and equity means. So shifting gears a little bit, so what is being done to improve disparities and barriers to care? We here at Special Olympics, in terms of looking to help improve some of these disparities and barriers, we have essentially 4 pillars, or we call it the path to health equity, that we focus on to help improve the health for again, for the athletes we serve, but hopefully again for all individuals across the state. And the first one would be prevention, which includes ongoing programs in health promotion, physical activity, fitness, child development, social emotional health, nutrition, prevention for all ages, from kids to adults. So this includes some of those programs that Kate mentioned, that SoFit, Fit5, education about nutrition, parts of physical activity. That's kind of all falls in there. While the second one is assessment, includes our health screenings and helping our athletes find follow-up care for providers in the area. So we do provide free health screenings to our athletes across 8 different disciplines. And one of the big key components of that is if we do identify any issues or needs that they do need to follow up with a provider, one of the areas that we kind of struggle with and are looking to improve is finding providers that, again, are trained, are comfortable working with people with disabilities that are in the area. So it's one where we can help our athletes, again, find the care that they need in their community through that pillar. The next one is training, which again, as I mentioned, is an opportunity for growth in terms of developing curriculum and training to equip the healthcare force to better serve and to be more inclusive of people with intellectual disabilities and other disabilities. And again, that's why it's exciting for conferences like this, where we're hoping to try to do and make more of an impact in that one. And then lastly, health system strengthening is more the advocacy work, finding partnerships, making policy changes at the local, national, and regional and global levels to help improve the health needs and elevate the voices of those with disabilities.
Some of my advocacy work that I'm doing is I have written legislation here in Minnesota that will help people with disabilities access obesity care. It's still kind of stuck in legislation. I'm hoping it will go somewhere this year. Another one is food insecurity. People with disabilities face food insecurity in different ways. One is being able to access transportation to go get food, as there aren't many resources, and SNAP offers online delivery, but it's only through depending on where you live, it's only 1 or 2 grocery stores, which makes it hard to get everything else you need for a specific week. Some research work that I'm doing. I'm a part of the Health Partners Community Advisory Council. I was a part of their digital health care research project, which is making electronic healthcare records and all digital healthcare more accessible. Transitioning from peds to adult medical care and taking charge of their own health. I'm doing some research around obesity, genetic research, such as the All of Us program. I am working to get people with disabilities added on to one of their subjects. And then Special Needs is doing a longitudinal study, which Jeff can explain.
Yeah, so the SOI, or Special Olympics International Longitudinal Study, is something that we've been asked here at a program level to participate in, and it's going to start next year. And it's a really exciting opportunity for us to be involved in a long-term study, because a lot of the data that we have and understanding of our athletes in terms of their health is very more focused on one single point in time. There isn't much data looking at long-term of how impact of getting involved in, again, whether it's Special Olympics or other health programs, how does that impact individuals' lives long-term? So it's an exciting time for us to be part of, along with 3 other programs, to participate in the study and look at, over 5+ years, how does being involved in, evidence-based health programming impact their lives, how much of an impact that can have improving their overall health. So it's a really exciting opportunity for us to be involved in that, and hopefully collect a lot of data that we can use and be able to share with not only with the Special Olympics community, but the entire state about, again, some of the impact health has on these individuals.
And then I am a part of the Health Partners Community Advisory Council, which they put together to help to make changes within their policies. I am one of two people with disabilities on that council. I'm the only one with an intellectual disability, and we've already started to see some changes along with disability care. And then health messengers.
Yeah, the last one, just wanted to highlight our Special Olympics Minnesota Health Messengers, which Kate is one of them. But essentially, these are athletes that are trained to be health and wellness leaders, educator advocates, role models within the Special Olympic community, and as well as the community at large. Their hope and focus on is being the example and leader for pursuing healthy lifestyles and advocating for changes, working with healthcare providers to adopt inclusive policies, and it's a great opportunity for them to share their stories and impact. And since this program has been launched in 2016, there's been over 4,000 athletes that have been trained to be health leaders and advocates. And for me as a staff member at Special Olympics, being able to rely on individuals like Kate and some of our health messengers are really, really beneficial for us to be able to share the impact, share the importance of policy changes, including athletes and people with intellectual disabilities in terms of policy, be involved in committees and councils. For example, like Kate said, she's involved in so many councils. But again, they have their voice and they are very able to share, and their stories are very impactful. So, and again, really the importance of this slide, what we want to highlight is, again, there is work being done to combat some of these barriers and issues. But there are also opportunities for you, whether you're a healthcare professional or a community member, to get involved. It's exciting to know that a lot of work is being done, but obviously there's still a lot more work to be done in order to make some changes.
Then our inclusive.
Oh, go ahead.
Our inclusive healthcare trainings. It's like Jeff mentioned that we are training providers and community partners to health professional schools to increase their knowledge and training of healthcare professionals, students that are working with IDD, to help them understand better when they encounter us, and then help med school students be better prepared to encounter us when they enter their practices. 84% of healthcare providers feel better prepared to treat people with intellectual disabilities as a result of volunteering Special Olympics.
And I feel like this is one of the ways we've been able to make the most impact in terms of making a difference in terms of healthcare professional and students. One of the really exciting things about this is, Kate and some of our athletes have been able to go into some of these universities, as I mentioned, and share their stories, much like many of the people in the previous sessions did as well. And again, your stories and your thoughts and your opinions go so much further than me talking, and it really makes a huge impact on the people that we've done trainings for. And it's been exciting to see students take what they've learned in our trainings and be able to get more involved. They've wanted to do more, they want to learn more, they want to be more inclusive. So it's really exciting to see where that has gone. And then kind of our last little bit, but what can you do as a healthcare professional to make an impact?
Offering inclusive spaces, welcoming spaces, ensuring that your programs and physical spaces are accessible and welcoming to people with disabilities. Communication, and the communication piece again, ensuring communication, including written and spoken language materials, interactions with the community are accessible. People with disabilities, such as plain language materials, making sure that the discharge summary is gone over with the nurse in the room. Also have that nurse help schedule any follow-up care that is needed. Awareness and training, understand that your community and training your staff on the barriers and challenges faced by people with disabilities, including how to remove them. Sustainable.
I didn't know, check my phone.
Intentional inclusion, building intentional sustainable inclusion by changing organizational culture to value and understand inclusion.
And then going a little bit more into the communication, like I said, because the second session did such a great job talking about this. So I'll try to highlight it really quick, but I think they hit on a lot of the key points in this as well. But again, communication is hugely important in helping to provide quality care, regardless if they have a disability or not. But again, being able to effectively communicate has been shown to have a positive relationship between the patient and the provider. It goes a long way helping to make sure that they follow through with medical recommendations, they manage a chronic condition, and then they adopt healthy behaviors. And the ability to explain, listen, empathize can have a profound impact on not only their biological, but also their functional health outcomes, as well as the patient's satisfaction and their overall experience of care. So again, some of the things that to kind of just keep in mind and highlight again are making sure that you're using a pace and a volume and tone that is typical and relaxed. Use clear communication that is easy to understand. This is both verbal and written. For that, making sure you're checking for understanding. Watch for nonverbal signs of confusion. Use more than one method to explain, show when possible. I know one of the ones that we always kind of give an example of, especially if you're working with younger children, are, if you do have, a stethoscope or whatever, or maybe it's a blood pressure cuff, allow them to touch and feel it, get more comfortable with it, so that as you're actually going to perform the whether it's blood pressure or checking their heart, maybe they're a little more comfortable with the equipment. Treat adults like adults. Speak directly to the athlete or individual as much as possible, and using people first language is huge as well.
Then other practical strategies: separate quiet waiting room and quiet sensory room. Develop a work plan with the patient. Fidget spinners, other toys to assist with anxiety. Dim lighting. Regular bubbles, liquid motion bubble toys, Play-Doh earplugs. Let the patient see, hold equipment, pictures show where you'll be examining. And then Special Olympics has created an All About Me form, which can help you better understand us and how to work with us. I don't know if I can, but we can send it out as a resource if you'd like it. And then be an advocate for us. Help us achieve our healthcare goals.
Yeah, I'll see if I can share the form really quick here, Kate. I'm gonna see if I can click out of it. But this is, if you can see it, this is the About Me form. And again, this is really great, as Kate mentioned, about trying to develop a work plan with your patient. But it allows whether it's the patient or a family member or caregiver can fill out prior to the appointment, where you can provide all their information. You can go a little bit into ways that help them stay calm and better understand. You can provide some little more details about why you're coming to the appointment, any other medical problems that they should be aware of. But it lays that out in a nice way for you and for the doctor to review, and this is available. That, like as Kate said, we'll send this out after the presentation, so you'll have this available. But it is a great resource that is available for you to use. Some additional resources and tools that I do want to highlight. We were fortunate enough to be a part of creating some videos with the support, or they did a lot of the work, but Minnesota Legal Aid created these videos where individuals such as like Kate were involved, and they're called Our Own Words, Improving Care for People with Disabilities. And there's 2 videos, one focusing on communication and one understanding disability. But again, these feature interviews of people with lived experiences discussing how they would like to be treated when they visit the healthcare provider. These are awesome videos. They're about 5 minutes in length. Again, but they again really highlight many of the things that that were discussed today in some of the previous sessions and in our session. But I highly encourage you to take a look at those and review them. Another one I do want to highlight is we do have a Center for Inclusive Health website that has a lot of great additional resources, guides, tools that you can use, additional information. And one of the big ones, which I'll show you on the next slide, is a provider toolkit that really goes into more detail in terms of things from general resources to breaking down into specific diagnoses that you can look to and provide more details and review that. And then the last one is the accessibility audit for healthcare settings. And this was developed by the Minnesota Department of Health. And I'm going to switch out here again. Here we go. This is the accessibility audit for healthcare settings.
This is Bridget. We can't see it.
Oh, no. Oh. Can you see my screen at all?
We can see the PowerPoint.
Okay. Shoot. Well, I'll send it out afterwards, but it is a great resource. But it really breaks it down into looking at different accessibilities, and that asks questions about, how you can review how well you're doing in terms of your clinic. So it looks into things around, not only around just in and around the clinic, but things such as like check-in and scheduling, things around scheduling appointments. But it is a really good resource. And again, it will be sent out afterwards. So I apologize that you can't see it. And then this is the main screen of that provider toolkit that I mentioned. But again, it goes into a lot more in-depth details of different topics. So again, like you can see general issues include things about more about communication, things about like informed consent, today's visit form, which is very similar to that About Me form. But then also looking into physical health issues, health watch tables, other things are in terms of behavior and mental health, and some additional resources. So that, again, if you are a provider, this is a wonderful resource to just get additional information and review it. And again, I highly recommend. I mean, it goes into things such as like medications and things like that. So this is a great tool if you're a healthcare professional.
And here are some quotes from several athletes. Look past disability and see us as a disability first. Get to know us. Get to know how we learn and communicate. Explain diagnosis in terms that we can understand. Make sure that the follow-up steps, such as important appointments, that you can help us to understand these steps and make those appointments before we leave the office. Ways to be inclusive in healthcare is to look past a disability to figure out what truly is going on with my health. Also talk to me, not my ride. You can, if you can't figure out what may be wrong with me, find someone who might be able to help. Treat us just like anyone with or without a disability. Please treat us as if we were other patients, but allow yourself to adapt to our unique needs. Work on a game plan and build together that best serves our needs without sacrificing quality of care that you trained hard and provided to so many over the years.
Again, hopefully these quotes that Kate shared, again, just reiterate a lot of things that were discussed today, in terms of what's important in terms of providing quality care for all the patients that you see. And then with that, it kind of wraps it up. If there are any questions, I haven't looked at the chat. So if there are questions in the chat, I know we have a few minutes that we can try to answer some of those. So thank you for sharing the audit, Jonathan, in there.
There's a few in the chat. There is one wondering how to address obesity in a way that isn't fat phobic or in a way that understands the needs of the fat patients. Ask us if you want to, if we want help with weight loss. Many of us do. Many of us, like myself, I have struggled for years with trying to figure out ways to lose weight, and it's hard because I can't find anything that's aimed at myself. Hence the reason why I'm writing legislation. We also need to work on getting rid of the SSI and SSDI earning limit out of the SNAP earnings, because that is what makes a lot of us ineligible. I myself only get $23 a month in SNAP, which is pretty much loaves of bread and gallons of milk. The All About Me form could work in an inpatient setting as well. I have created one that I used on my phone that a healthcare provider can access, and the emergency, the EMS people and the police can access as well, so they can better understand work with me and learn can see my, if I'm anxious, and they can learn my cues. And those forms could be pinned in their electronic health records as well. Any other questions?
Well, thank you so much. It looks like we are at time. So thank you, Jeff and Kate. I really appreciate your presentation today. I found it very informative. And thank you for bringing this content for today. This concludes the continuing medical education, or CME, related content for the conference. So thank you all for participating in today's conference, Disabled, Not Disposable. We hope you learned some valuable skills to advance health equity for your patients with disabilities. Please take a moment to complete the post-conference evaluation by scanning the QR code that you see on the screen, or by clicking the link that will be posted in the chat. I'm sure we'll also have the link available in other formats as well. We value your feedback and use this information to inform future conferences and improve the CME program at Gillette Children's. And for those claiming CME credit, you will receive an email from Gillette Children's with a certificate of attendance and link to the post-conference evaluation. Once again, thank you for all of our sponsors, our cohort organization, and planning committee members, faculty members, and you for attending, for making this conference a great success. However, don't leave quite yet, because we now have an opportunity for participants to ask additional questions to our conference planners and speakers, and to provide feedback for additional sessions and aftercare support. But we will take a quick 5-minute break at the moment, and then resume at 2 o'clock for an explanation on our next breakout session. So I will look forward to having everyone back at 2 o'clock. So